Now I would like to invite Mrs. Ferganza Zubilson, ma'am, Assistant Professor of Department of Medical Surgical Nursing, for opening of the theme.
Thank you, Ms. Mansi Kampi. A very good morning to all of you. Half of Medical Surgical Nursing Department, MGM New Bombay College of Nursing, we are pleased to bring this national webinar on system recognition, Save a Beat. Electrocardiogram is a diagnostic tool that is routinely used non-invasively to assess the electrical functions of the heart. ECG has also made a focal point of modern medicine because it provides information about diagnosing different cardiac arrhythmias. Nurses are usually the first responders in hospital to different cardiac emergencies. Therefore, they must be masters to recognize basic ECG rhythms since they are responsible for monitoring and clinical decision making. Few research studies expressed that nurses did not know the right cardiography monitoring and could not recognize different type of arrhythmias immediately. Inappropriate interpretations in turn increase the cost of healthcare and delay the admission process, which may impose an unpleasant burden on both hospital and patients. Keeping in mind the current need of the hour to improve the skills of graduating nurses and student nurses to interpret ECG and identify arrhythmias on time, we came up with this webinar to help student nurses improve their knowledge in ECG. So I'm pleased to introduce our renowned speakers of the day. There will be 3 sessions in this webinar. The first session will be dealt by Mrs. Sridevi, nurse practitioner, MGM Hospital, Kamote. The second session, interpretation of abnormal rhythm, will be dealt by Dr. Shilpa Kadam, Professor, Department of Cardiology, MGM Hospital, Kamote. Third session will be dealt by Dr. Kotkodi Arjunan, Reader and HOD, Department of Medical Surgical Nursing, Sri Ramachandra Institute of Higher Education and Research. I welcome all the respected resource person of the day and sincerely thank them for accepting our invitation in a very short notice. I hope this national webinar will be a very fruitful one for each one of us. Thank you, one and all.
Thank you, ma'am. Now I would like to call Mrs. Sridevi, nurse practitioner, MGM Hospital, Kamote. She is a postgraduate in MSc, nurse practitioner in critical care. She has an experience of 14 years in clinicals. She is currently working as a nurse practitioner in critical care, EMS ICU at MGM Kamote. Her achievements are she has received the Chancellor Medal in post-graduation, resource person in various national and international webinars, publications, manuscripts published in the year 2020. I would like to welcome Mrs. Sridevi for taking.
Thank you, Mansi, for the wonderful introduction. And good morning to all. Good morning, Prabhama, all my teachers. And very good morning to all those who are presented today. Mansi, ma'am, thank you for giving me an opportunity to share my knowledge. Mansi, my slides are okay. Is it visible and I'm audible? Hello?
Yes, your slides are visible and you're audible.
Yeah, thank you. So today's session topic is basics of ECG, normal sinus rhythm. So it's very important to know the normal sinus rhythm, to know the abnormalities in the ECG. Right. So the goal of today's session goal is to have a basic understanding of conduction system. Start this. Everything out. The goal of the session is to understand the conduction system, ECG waves, and interpretation of normal ECG. So if we look into the history of ECG, this Italian scientist Carlo Matteucci, who realizes the electricity associated with the heartbeat in 1842, and William Enthoven, who predicted the invention of ECG in 1895, and he diagnosed some heart problems by using the string electrometer in the year of 1905-06, and he won the Nobel Prize for Physiology of Medicine for his work on ECG in 1924. So what is electrocardiogram? ECG stands for electrocardiogram. ECG in some countries, the abbreviation is used EKG. ECG and EKG are same. So what the definition? So the ECG, the definition itself, there is in the word itself, electrocardiogram. Electro means electricity, cardio means heart, and gram something you visualize. So it is the electrical activity of the heart represented graphically. That's ECG. And in the ECG records where the electrical impulses start and how they flow through the heart. And it doesn't measure how well the heart is pumping. First, have a review of anatomy, cardiac anatomy and physiology. The location of the heart is located behind the sternum in the mediastinal cavity between the lungs in front of the spine, and base of the heart just below the second rib, and apex of the heart is towards related on the left side, and intercostal space rests on the diaphragm. Heart chambers, there are 4 heart chambers, 2 atrial and 2 ventricles, and those are separated by interatrial and interventricular septum. Heart valves, there are 4 valves. Between the right atrium and right ventricle, there is tricuspid valve. Between the left atrium and ventricle is mitral valve. There are 2 valves, those are pulmonary and aortic valve. So there is a connection system. The heart, the internal pacemaker is called SA node. It is on the right upper part of the atrium. As you can see here, the impulse start from the SA node via internodal tract, that is posterior, middle, and anterior. And then from AV node, it passes to the bundle of His, and then to right and left bundle branch, and then to the Purkinje fibers. So the conduction, you can see here the conduction system at the AV node, it's a bit slow, and then the speed picks up at the bundle. Right bundle branch has only 1 branch, but the left bundle branch has another division, that there is posterior and anterior branches. Those are called fascicle. And also there is 1 branch which goes from SA node to the left atrium. For the left atrial repolarization, there is 1 branch that is called Buckman bundle. So the first thing that from the atrial polarize. So what is depolarization? Depolarization is when action of any muscle is associated with electrical changes called depolarization. And repolarization is the relaxation of muscles. So from the SA node, we traverse to the left atrium, and the atrium, both atrium contracts together, and then later on it comes down and it depolarizes the ventricle and the ventricle contracts. That's how the conduction, the normal conduction system happens. So let's see pacemakers of the heart. The dominant pacemaker is SA node that can produce impulses at the rate of 60 to 100 beats per minute in an adult. That's a normal heartbeat, 60 to 100. And in case that AV node fails to initiate impulse, AV node also can, that is a safety mechanism. AV node also can initiate impulse as a backup pacemaker at a rate of 40 to 60 beats per minute. If SA node, AV node fails and if we don't initiate the rate, then ventricle cells also can initiate. They also have the capability to initiate the impulses at the rate of 20 to 40 beats per minute. So each heartbeat is represented by one Ecg complex, and each complex is composed of 5 parts. There's P wave, Qrs complex, P wave, PR segment, ST segment. So when the Ecg, the atrium, when both atrium depolarize, you get P wave on the Ecg. So P wave represents atrial contraction or atrial depolarization. And the first half of the P wave, it represents the right atrial depolarization, and the second half denotes left atrial depolarization. And then you get a Q wave when the depolarization of the ventricle, and the T wave you get on the Ecg when the recovery phase or the repolarization of the ventricle. So P wave is atrial depolarization, Q wave, atrial repolarization, Q wave, Qrs complex, ventricular depolarization, and T wave you get during the ventricular repolarization. So now where is atrial repolarization? There's a question, where is atrial repolarization? So now the Qrs complex during the ventricular atrial repolarization happens. So this dominates the ventricular depolarization. Qrs complex, dominates. So you are not able to. There is no Ecg changes. You can see the when pertaining to the atrial repolarization. It masks the Qrs complex masks actually the atrial repolarization. The basic terminologies that you need to know when you read the ECGs, the baseline. What is baseline? Which is a flat, straight, and isoelectric line. Okay, that is flat line, and waveforms, deviation or movement away from baseline may be upward or downward. Segment, a line between two waves. Like PR segment, ST segment, those are segments. For the interval, a waveform plus a segment, this shows time duration. That is PR interval or QT interval. We said so these are interval, and the complex combination of several waveform without a segment, that's Qrs complex. Placement, there are 4 limb electrodes and 6 chest lead that need to be placed when you intake an Ecg strip. So to place the limb electrode, there is a mnemonic that you can use to remember the color coding of the limb electrode. Says right, pure, green, white. Okay, so R is for right and R is for red. So you can place the red color electrodes on the right arm, and then you go clockwise. So yellow on the left arm, green on the left leg, and black on the right lower limb. So placement of the limb electrode is very easy, and there is no specific position to remember. Try to find the least hairy area and avoid bony prominence. And on the upper limb, anywhere from the shoulder or outer clavicle down to the wrist is fine for the upper limb. Lower limb, anywhere from the lower abdomen to the foot, right and left side is fine. But when you give the chest lead placement, the the placement should be very accurate. So the V1 to V6 placement, the V1 should be kept on the fourth intercostal space on the right side of the sternum. V2 on the left side sternal border, the fourth intercostal space. V4, the mid-clavicular line at the fifth intercostal space, and V3 between V2 and V4, and V5 at the anterior axillary line, and V6 at the mid-axillary line. So how do you find the fourth intercostal space? Just below the clavicle, you calculate, you get the rib, that is the second rib. Just below that, the second intercostal space. So you calculate and come down, and you can find out the fourth intercostal space. So this slide you can see a normal Ecg rhythm. So here you can see lead 1, lead 2, lead 3, AVR, AVL, AVF, and V1 to V6. So lead 1, lead 2, and lead 3 are called bipolar limb leads. AVR, AVL, AF augmented limb leads, and V1 to V6 is the precordial test leads. Okay, so the V1, V2, these leads, Ecg, that doesn't mean that the electrodes that we are placing on the patient. These are the leads which are formed due to the electrical activity, like lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V6. So the lead 1, lead 2, lead 3, I said it is a bipolar limb lead. And how it's formed? The right atrium, right arm electrodes and left arm electrodes. The lead Ecg can goes to So then the right arm, there's a negative electrode and the positive electrodes on the left arm that joins together, forming the lead 1. Lead 2 formation, right arm and the lower limb, and the left, lead 3 is the left arm and lower limb. So that's how it is formed. And also the palliate Ecg can be used to determine coronary artery that is most likely affected by the ischemic event. Here in this picture, you can see the inferior wall is supplied by the right coronary artery. So any ischemia or events which happens, in the right coronary artery, then it affects the inferior wall of the heart, so that any changes in the lead 2, lead 3, and AVF. And we can say it's a inferior wall impact. And the lateral wall consists of lead 1, AVL, and V5, V6 is a lateral side, and septal V1 and V2, and anterior is V3, V4. So the right side, the right coronary artery changes, as you can see in the inferior, lead 2, lead 3, and AVF. The other changes that you can see, if the left coronary artery is affected, the other leads, you can see the changes. So on the Ecg paper, there are small boxes and big boxes. So the big boxes, there are in the big boxes, there are 5 small boxes horizontally and vertically. Horizontally, it records time, and vertically, it denotes voltage. And each one small box is 0.04 seconds. So the vertically, horizontally, there are 5 small boxes in a large box. So one large box is 0.04 multiplied by 5. So you get 0.2 seconds. And vertically, one large box is 5 mm. Each small box is 1 mm. 1 mm. So first, what you need to look into the standardization of the Ecg paper before reading the Ecg. So each Ecg paper has speed of 25 mm per second. And in this Ecg, you can see on the left-hand side, left corner side, there is a square. So why it is given on each and every Ecg paper, that is significant. The size of the Ecg, the square should be 2 big boxes height and 1 big box width. So that if the height of the squares are more than what is normal, then you get a high amplitude waves, or you get if it is short, then you get a low amplitude waves. Low amplitude waves that we get in the pericardial infusion, or the high amplitude you may get the hypertrophic patient. So you may misdiagnose if the standardization is not proper. So there is a stepwise approach to read the ECG. The first one is rhythm, then second rate. You need to calculate the heart rate, axis. Then you look into the P wave, and then QRS complex, P wave, and ST segment. The first thing that you need to check the rhythm, whether the rhythm is regular or irregular. So how do you find whether it's a regular or irregular rhythm? Irregular, that means the same number of squares between
Ma'am, you're not audible.
the cells.
Ma'am, you're not audible. Due to technical issue, Madam got disconnected. She will joining us soon.
Hello, am I audible?
Yes, ma'am, you're audible
Hello.
now.
Okay. The first thing that you need is
Ma'am, your voice is not coming clear.
hello.
Yes, ma'am.
Is it okay now?
Yes, ma'am.
Okay. So the variable between each Qrs complex. So in this ECG, you can see that is the first one is a regular rhythm between Qrs complex. There is equal number of boxes. But the second it's irregular rhythm. You can see here the boxes are more. The number of boxes are more, and here it is less. So it's an irregular rhythm.
Ma'am, your voice is breaking.
Hello.
Yes, ma'am.
Okay, now.
Yes, ma'am.
So, yeah, the rhythm you need to check regular, whether it's regular or irregular. Yeah, the second is finding out the heart rate. So there are the first method. There are various methods to the heart rate. The first method is rule of 300, and this method that you need to memorize these numbers. The number of big boxes between two R waves. Between two R waves, if there is only one big box, then the heart rate is approximately 300. And if there are two big boxes, it's 150, 300, 475, 560, and 650. This is one method that you can calculate the heart rate in an easy method. The second method is the 300 divided by number of big squares between RR interval. So in this ECG, the 300 is constant number. So in this ECG, you can see how many big boxes are there? 1, 2, 3, 4. So in the 300 divided by 4, it's 75. The other third method is 1500 divided by number of small squares between the RR interval. So the RR between the RR interval, how many small squares are there? 20 small squares are there. So 1500 divided by 20, that's 75. So these three methods you can use when the ECG is irregular. But if it is irregular, then there is another method that you can calculate the heart rate. You need to, this is a 6-second, count the number of Qrs complex within 6 seconds. 6 seconds means the 30 big boxes. So that within that 30 big boxes, the number of count the R waves, Qrs complex, and multiplied by 10. So in this ECG rhythm, you can see there are 7. This is 30 big boxes are there, and there are 7 Qrs complex. So 7 multiplied by 10, it's 70. So when it is irregular, you can use this method. So can you all calculate the heart rate on this ECG rhythm? Just a question. And put it in the answer, you can put it in the chat box. Okay, calculate the heart rhythm. You can use any method. Approximate heart rate. So only one person gives the answer. Others are sleeping. Hello? All are here? We calculate the heart rate on this ECG strip. There are total 4 methods. So Snell answer, Snell, it is correct. Approximately it's 150. Okay, you can see 2 large boxes in between the Qrs complex. So there is 2 big boxes, 2 large boxes, it's 150. The next is look into the axis. The axis, it can be normal, left axis deviation, or right axis deviation. So the normal axis, you can look into the lead one and AVF. Okay, if in the both the lead one and AVF, if it's a predominantly positive, the Qrs complex is predominantly positive, that is normal axis, and in lead one, if it is the Qrs complex is positive, and in AVF, if it is negative, then it is said to be left axis deviation. And in the lead one, if it is negative, you can see this picture. In the lead one, if it is negative, and in AVF, if it is positive, then it is said to be right axis deviation. This is one of the easiest method, the quadrant approach. And in some cases, it can be normal, the lady, and in all very thin patients, you may get right axis deviation, and very short and the short and obese patient, you may get this LAD on the ECG. That's why sometimes it is normal. But however, the presence of axis deviation should alert you to look for other signs and other signs of right and left ventricular hypertrophy. And right may suggest pulmonary embolism, and left may suggest the conduction. Left axis deviation may suggest conduction problem. So then the next step is to look into the P wave. So the P wave on the ECG, I said it's a atrial depolarization. When the atrial depolarize and contracts, you get a P wave on the ECG paper. So when there is the P wave, it's that P wave is the first positive deflection on the ECG. Sorry. Yeah. So one P wave, there should be one P wave per QRS complex. It should be round and upright, and you can best visualize in lead 2. So what are the other things that you need to look into the P wave? And also the height of the P wave, that is 2.5 mm, that is 2.5 small square, and width is 2 to 120 millisecond, that is 2 to 3 small square. So what are the things that you look into when you look for a P wave? The first thing that you see, whether it's a present, is the P wave present or absent? And whether is it positive or negative or biphasic? And the amplitude, whether it's increased, decreased, or normal. Rounded, upright, deep, flattened, or M-shaped. Is it present? Is QRS complex, and does it have same shape and morphology? These are the things that you need to look into when you look for P wave. And the QRS complex denotes ventricular depolarization and contraction. The normal QRS complex, within 0.12 second, that is 3 small boxes. Within the 3 small boxes, size of the QRS complex. So when you look into the QRS complex, see that is the width of the QRS complex is normal, widened, or narrowed. Are there any pathological Q waves? Okay, the Q wave is the first negative deflection on the ECG, but sometimes in normal case it may not be present in some leads. And when you can say when the size of the normal Q wave, it shouldn't be more than 1 small square. So if there is the size, if it is more than 1 small square, then you can say it's pathological Q wave. And are there any delta wave present? Is the amplitude of QRS complex normal, high, or low? And is there normal R wave progression in the precordial leads? The precordial leads means V1 to V6, there should be a R wave progression. R wave is very small in V1, and it gradually increase until V5, and then V6 is a bit less than the V5. There has to be a R wave progression from V1 to V6. The next thing that you need to look for T wave. T waves are T wave represents the ventricular repolarization, and it is asymmetric, smooth and round morphology, amplitude less than 5 mm. So when you look into the T wave is always upright in lead 1, lead 2, V4 to V6, and inverted in AVR. In AVR, all leads are inverted. Okay. And it may be inverted in V1, 2, that is also normal. The amplitude of a normal T wave is 1/3 to 2/3 that of the corresponding R wave. So, and the highest amplitude of the T wave is usually seen in V2 and V3. The T wave usually corresponds with R wave, and wherever there is a positive R wave, so we expect that T wave also in normal case is positive. So the PR interval, how you measure the PR interval? The beginning of the T wave to the beginning of the QRS complex. That's a PR interval. So normal PR interval is 0.12 to 0.2 second, that is 3 to 5 small boxes. You need to look for the PR interval, whether it's a prolonged or very short. And so prolonged PR interval you may see in blocks, and a very small, very short PR interval you can see in WPW syndrome. And QT interval, the normal QT interval, have you measured the QT interval? The QT interval, the starting of the Q wave till the ending or end of the T wave, that is the QT interval. The QT interval normal is 0.32 to 0.40 seconds, that's 8 to 10 small boxes, and it varies in males and females. In females, it can go up to 0.44 seconds. So there are some, drug toxicity can cause a prolonged PR interval. Prolonged PR interval always should be very cautiously we need to take, because that can have a ventricular arrhythmia and fatal condition can have. So that really need to be treated. The ST segment is the segment where the ending of the S wave till the starting of the T wave. This is called the ST segment, and it is isoelectric. Isoelectric means it's in the same line. And PR segment and ST segment, always you check with the PR interval. If it's the same line, it lies same, or it should be the PR segment and ST segment should be on the same line. And if it is above or below above, then you can say it is a ST elevation, and we look for ST elevation or ST depression. In ischemic changes, you get ST elevation and ST depression changes. So the normal sinus rhythm, ECG rhythm characterized by a usual rate of anywhere between 60 to 100 beats per minute in adult. Every P wave must be followed by a Qrs complex, and every Qrs is preceded by P wave. So that is sinus rhythm. Always when there is P wave, that means it is the impulses are initiated at the SA node. When there is when we say it is a sinus rhythm, the P wave has to be present. And normal duration of PR interval is 3 to 5 small squares, and P wave is upright in lead 1 and lead 2. In conclusion, normal ECG values are the heart rate 60 to 100 beats per minute, PR interval 0.12 to 0.20 seconds, Qrs complex less than 0.12 seconds, that means 3 small boxes, and QT interval less than 0.40 seconds, and P amplitude less than 3 mm. Does anyone have any question? It's all about the normal basics of ECG. If you have any question, you can put it in the chat box, or you can unmute yourself and can ask questions. If you didn't understand any slide, you can. So if there are no questions, can I wind up? Thank you.
Thank you, ma'am, for that excellent presentation. If you have any questions, please add them in the chat box below. Miss Ashwini has raised her hand. If you want to ask any question, please put it in the chat box. Ma'am, there is one question by Ashwini. She is asking that could you please explain us one more time regarding repolarization and depolarization? As the voice was breaking during that.
Okay, fine. All right. So the depolarization, when the when this is nothing but when the electrical impulses pass through the cells. Okay, this electrical, the negative and positive ions exchange happens between the intracellular and extracellular space. So the this is from when the impulses initiate at the SA node, it travels from cell to cell and then depolarize the whole atria and the whole ventricle. Due to the electrical exchange happens within the cells. So that's called that is called depolarization. And just once a depolarization complete, the atria contracts. Okay, and then the ventricular during the ventricular depolarization, just when we complete the ventricular depolarization, the ventricle contracts. Is that okay, Ashwini?
Thank you, ma'am, for explaining once more regarding repolarization and depolarization. Anyone, if having any queries related to basic of ECGs, can put the question and A session. Ma'am, there is one more question. There is a doubt regarding axis deviation. Could you please explain us more about axis deviation, ma'am?
So axis deviation, on the ECG, it can be, sometimes it is normal, the axis, the axis, when you look into the axis, whether it is a normal left axis deviation or right axis deviation, you need to look into the, this is one of the easiest, there are many other methods, this is one of the easiest method. Look at the lead 1 and AVF, okay. Why it is, what is the significance? Right axis deviation, that means there is some pathological abnormalities in the right side of the heart. This, most of the time the pulmonary embolism which affects the right ventricles and right atrium. So right atrial hypertrophy, the right ventricular problem that can pick up, or that will show in the ECG as a right axis deviation. And on the left side of the heart, like LVH or some ischemic on the left side, then you get left axis deviation. And sometimes it is normal, as I said. The tall, thin people, you may get a right axis deviation, and obese, short patient, sometimes you get left axis deviation. That is normal. So how to look for the normal axis, left axis, and right axis deviation? So look at lead 1 and look at AVF. Okay. So if in the both leads, as you see in this ECG, both the R waves, like Qrs complex predominantly, it is positive. It's positive deflection. So that is normal. If the lead 1 It's a positive deflection, and in AVF, if it is negative deflection, okay, it's living away. So that you just to remember, living L is for living, and so that is LAD, left axis deviation, and right axis. Look at lead 1 and AVF. If in the lead 1, if it is negative, and in AVF, if it is positive, that is RAD, right axis deviation, that is returning each other. Each waves are returning. Okay, so R for right axis deviation. Just to remember that example like it.
Thank you,
Is that
ma'am.
okay?
Thank you, ma'am, for clearing all their doubts.
Thank you, Nancy.
Thank you for your valuable time, ma'am. It was a wonderful session.
It's my pleasure. Thank you.
Now let's welcome Dr. Shilpa Kadam. Dr. Shilpa Kadam is MD, Interventional Cardiologist, MGM New Bombay Hospital, Vashi and CBD, Belapur. Professor in Department of Cardiology, MGM Institute of Health Sciences, Navi Mumbai. Has successfully done more than 5,000 interventions in adult and pediatric age group. She has several publications in national and international journals to her credit. Now I would like to welcome Dr. Shilpa ma'am. Over to you, ma'am.
Hello. Yeah, I'm there. I'm there, ma'am.
Yes, ma'am, you're audible.
Yeah, I will connect, ma'am. Ma'am, am I seen? Hello?
No, ma'am.
My screen is not seen?
No, ma'am. Slides are not visible.
I will try again, ma'am. Ma'am, is it seen now?
Yes, ma'am.
Okay. So very good morning to everyone. Thank you so much for inviting me for this talk. Today we'll be learning interpretation of abnormal rhythms. In interpretation, I'm Dr. Shilpa Deshmukh Kadam. I'm interventional cardiologist at MGM Hospital, Navi Mumbai. So Sridevi has already covered a lot of basics of ECG. Now we need to learn about abnormal rhythm. So to learn about abnormal rhythm, we need to know what is a normal rhythm first. So to understand what do we call a sinus rhythm, we need to know about the basics, that the impulse is generated at the SA node in the right atrium. It travels to the AV node in the right atrium. From there, it travels to the bundle of His. Bundle of His gets divided into the right bundle and the left bundle. Right bundle divides into his Purkinje fibers later on. The left bundle divides into left anterior fascicle and left posterior fascicle, which again bifurcates into the his Purkinje fiber system. So we need to know that on the ECG, we have normal waves, that is P, Q, R, S, and P. The P wave is generated due to depolarization of the atria. It is both the atria, right and left. The QRS wave is generated due to the depolarization or contraction of the ventricle, depolarization of the ventricle. The T wave is generated due to the repolarization of the ventricles. So we should know what is the normal intervals in all this PQRST system. So normal P wave, P starting of the P wave to starting of the Q wave is called as the PR interval. It is normally less than or equal to 120 milliseconds. The QRS duration has to be up to 200 milliseconds. So about 200 milliseconds, we call it as abnormal. QT interval is from the starting of the Q wave to the ending of the T interval, ending of the T wave. So QT duration, it has to be less than 440 milliseconds in women and less than 460 milliseconds in men. So there is a U wave, sometimes it comes, which denotes the atrial repolarization. So it may not be seen in all the waveforms. We have to see that RR intervals are normal. Let's go to the next slide. So we should know what exactly we denote the waves as. If it is a positive wave, only positive wave in the QRS, it is called as a R wave.
Sorry to
Similarly,
interrupt, ma'am, but your slides are not moving.
Not moving?
No, ma'am.
So which slide are you seeing now?
Second slide.
Okay, so second, the heart and ECG you are able to see. Are we seeing the next slide now? Are we seeing the next slide? Am I audible? Okay.
You're in the fourth. Yeah, now it's moving. We can
It's
see
moving,
it.
no? Yeah, okay.
Yes, yes.
So talking of the QRS complex, we need to know what nomenclature we are using. So the first positive wave on the ECG in a QRS complex is a R wave. The first negative wave on the ECG is a Q wave. So depending upon the amplitude of the wave, we label the QRS complex. If we see a tall R wave and a small negative complex, that is capital R and small s. So when we are talking about this, we should know what is a RS complex, what is a RSR pattern, RSR or a RR dash we call it, that is a small R wave followed by a large R wave is called as RR dash pattern. RSR is we see double 2 R waves. This is seen in RBBB or LBBB. We'll get to it slowly. So just we should know the nomenclature, basic nomenclature. If we see only a negative wave in the place of a QRS complex, it is called as a QS complex. So let's go to the next slide, which shows that the heart rate calculation. I think Sridevi has already covered about the heart rate calculation. I prefer this formula, that is rate should be 1500 divided by the small squares in 2 R intervals. So if there are 5 small squares in 2 RR, between the 2 RR, then we say 1500 divided by 5, that is 300 beats per minute is the heart rate. So knowing this is particularly very important when we want to know what exactly we call as a tachycardia, what exactly is a bradycardia. So we all know the normal heart rate is between 60 to 100 beats per minute. So less than 60, we call it a sinus bradycardia. More than 60, we call it as a sinus tachycardia. So let's see slowly. We have learned about the hexaxial reference system, I guess. We all know. So our hexaxial reference system gives us an idea about the axis of an ECG. It is essential to identify when we are talking about LV hypertrophy or RV hypertrophy or abnormal ECGs. So in that, we need to know the axis. The axis is essentially divided into 4 quarters. Between 0 degrees to positive 90 degrees, plus 90 is the normal axis, or minus 30 to plus 90 is the normal axis. Plus 90 to plus 180 is the right axis. Minus 30 to minus 90 is the left axis. And minus 90 to minus 180 would be extreme right axis or a northwest axis, we call it. So let's see how do we differentiate or how do we broadly divide an abnormal rhythm on an ECG? So abnormal rhythm on an ECG can be divided by its regularity or rhythm, whether it is regularly irregular or irregularly irregular. It can be divided depending upon the heart rate. So whether it is a fast, that is tachycardia, heart rate of more than 100, or a slow, where the rhythm is slow and the beats are less than 60. So we call it as a bradycardia. And the origin of the ECG or the Qrs complex, basically we are talking about whether it is supraventricular or infraventricular, or supranodal and infranodal. Supranodal should always have a narrow Qrs complex, and infranodal rhythms, rhythms which originate below the AV node, are called as infranodal rhythms. They usually, as we all know, have a lower rate of 40 to 60 beats per minute, and they have a broad Qrs complex. Whereas supranodal rhythms have a narrow Qrs complex, and they have a narrow Qrs complex. Yes, the rate may differ. Now we'll go to one by one. So what ECG is this? Can anyone guess? Is there anyone there to guess this? So this is basically a normal ECG. I wanted to confirm with you guys what exactly is a sinus rhythm. We need to exactly identify what is a sinus rhythm. In a sinus rhythm, it is very essential to identify that every Qrs complex is preceded by a P wave. Qrs complex, P wave, Qrs complex, P wave. So if we are seeing P wave before every Qrs complex, it means it is a sinus rhythm. This is a sinus ECG. And if we see, there are like 15 small squares between two RR complexes. So it is like heart rate of 100 beats per minute. So it is within the normal range with the sinus rhythm. Only one variability we are able to see is that the RR is variable. We can see there are regular RR and then there is a longer beat. Then again a regular RR. So why we are seeing this? There is a narrow beat, there is a very long pause in between. So this is a sinus rhythm, but there is a arrhythmia. So this is called as a sinus arrhythmia. So 100 beats per minute would be the rate. The rhythm is sinus arrhythmia and rhythm is sinus rhythm. So let's go to the next slide. Here we have classified the SA nodal disease. Sinus node in the heart, in the right atrium, is known as the pacemaker of the heart. And if it gets diseased due to any reason, maybe some structural problems, or maybe the blood supply to the sinus node is not enough. So if the blood supply to the sinus node is not enough, it may not work well. Or with aging, normally we get to see above 65 years, 65 to 70 years, when the sinus nodes starts getting diseased and the heart rate gets slower or faster, or heart starts behaving abnormally. So here we see the baseline ECG where we are seeing the Qrs complex, Qrs complex. So this is a normal ECG. In the second time, in the second rhythm, we are able to see that Qrs normal. In this Qrs complex, the distance between the two P waves has decreased sequentially. So in between the first P and the second P, we see the distance is 780 milliseconds. In between the second P and the third P, we see the distance of 680 milliseconds. And then we see a little longer pause. So here there should be a third Qrs complex, P and Qrs complex, but we are not able to see it. Complete absence. So this is called a sinus node disease, type 2 sinus node disease. And this is called as a sinus node Venke-Batch phenomena, where we are not able to see a complete Qrs complex. So if sinus node is diseased, we don't see a P wave, because P wave is generated from the sinus node. It travels down to the ventricles to generate a Qrs complex. So when P wave is not there, there cannot be any Qrs complex. So type 1 Venke-Batch SA nodal block is when we see that there is progressive shortening of the PP intervals followed by a pause. So this is type 1. In type 2, we get to see that the PP intervals are regular. They are coming at a regular interval. That is 1280 milliseconds, 1280 milliseconds, and 1280 milliseconds. Only thing which we are not seeing is we are missing a complete PQRS complex. So complete PQRS complex is absent, but otherwise the rhythm appears normal. It means it is a type 2 sinus node, sinoatrial exit block. Means the impulse is generated, but it is not able to come out. So these two ECGs, PP becomes shorter. One beat is completely missed. Here PP remains almost the same, but one PQRST is absent, completely absent. And the third one is known as the third degree SA block, where you're not seeing any complex being generated by the no P wave, no ECG being generated by the SA node. But because there is no generation of ECG or no generation of beats by the SA node, the lower nodes like the AV node, the ventricles, Purkinje fiber, his Purkinje system comes into action, and we get to see a QRS complex, which is known as the nodal rhythm. Here we are not seeing the P wave at all. We only see a QRS complex. This is known as the escape rhythm. In escape rhythm, the rate may vary. It may be rhythm may have no P wave, QRS complex, a rate of 40 or a rate of 20 also sometimes. So it depends on whether it is being generated. Because SA node is not working, it is being generated by the AV node, by the bundle of His, or by the His Purkinje system. Also, as I told you, if it is a narrow QRS complex, we say it is supranodal. If it is a broad QRS complex, that is more than 120 milliseconds, the QRS diameter is, then we call it as a infranodal disease. So this is about the sinus node dysfunction. So coming to the next slide, what this slide indicates is a very important thing. What we can see, a normal regular sinus rhythm, but in between we see very long pauses. So very long pause. So as we all know, each small square denotes that it is 0.04 seconds. So if we see each of the 5 large squares, that is 200, 0.04 into 5, that is 20. So 20 into 5, this will denote 1 second, 10 and 15. So this is like 15 large squares denote that it is 13, that it is 3 seconds pause. So if we see a 15 large squares, then it is a 3-second pause. If it is more than 3-second pause, it is definitely taken as an abnormal rhythm, and it has to be if the patient is symptomatic. If this is the state, patient suddenly falls off. You might have heard of patients who suddenly fall off while walking, while driving, they meet accidents. No one knows what is the cause. So there could be a sinus pause. This is commonly seen in elderly patients. No one knows, no reason is known. But then retrospectively, sometimes they say there was chest pain. Sometimes they say, no, there was no chest pain. Suddenly the patient fell off and died. So this could be the reason. If patient is symptomatic, if patient is presenting with giddiness with such sinus pauses, then this is a first degree indication for permanent pacemaker. So this is called as 6 sinus syndrome. When the sinus node is not working, why we say sinus node is not working and why not AV blocks? Because we cannot see any P wave also. It's a flat line. There is no P wave, and in this particular patient, there is no escape rhythm, there is no nodal rhythm, there is no QRS complex at all. And then sometimes the sinus node recovers and you see a normal sinus tachycardia. This is a sinus tachycardia. So this ECG everyone can identify, but it is a very, very dangerous ECG. We all should be aware about it. And we should know what all to do. We have to put this patient on temporary pacemaker for the time being and plan for permanent pacemaker. So let's go to the next slide, which shows second degree heart block or AV block. So in the AV block, atrioventricular nodal block, what happens is there it is divided into 3 parts. The first is a first degree AV block. So first degree AV block, only the P to QRS distance gets more. So it is increased. How much more does it increase? This is more than 200 milliseconds. So P means starting of the P wave to the starting of the Q wave. This is taken as PR interval. And this PR interval is prolonged for more than 200 milliseconds. 200 milliseconds, how it comes? This is 5 small squares plus 2 small squares. That is 7 small squares, 7 into 0.04. So it comes as 200 milliseconds or more than 0.20 seconds. So 200 more than prolongation of more than 200 milliseconds is known as first degree AV block. This is, we are talking about the AV node. In the second degree AV block, it is divided into two types. Type 1 is known as the Venke batch or Mobitz type 1. Type 2 known as Mobitz type 2. So in what happens in type 1? In type 1, we see the PR duration, it goes on steadily increasing. So it is like, looks like normal here. It is slightly increased, it is more increased, and then we see a P wave, but no QRS. So there is a dropped QRS complex after steadily increasing PR interval. So if this is the case, we call it as a Venke batch phenomena or Mobitz type 1, second degree Mobitz type 1 heart block, this is called. Then in the second degree Mobitz type 2 heart block, what exactly happens is we see a P wave which is being conducted but no QRS complex. The PP intervals as we see remain normal. The RR intervals also are remaining normal, but we don't see a QRS complex at all. So in this case, it is known as Mobitz type 2 second degree heart block. The third type of heart block is third degree heart block, where we get to see that the P to P interval remains normal. P to P interval, this is P, this is P, to this is P, to this is P. So it remains normal. R to R interval also remains normal. If we see R to R also remains normal. But there is no correlation between P and QRS. So you can see the distance between P and QRS keeps on varying. So this is a third degree heart block or a complete heart block. P to P remains normal, R to R remains normal, but there is no correlation between P and R. In second degree Mobitz type 2, you also get to see that there is no QRS, but P to P remains normal and P to R also remains normal in the leads which are having a normal beat. So P to P is remaining normal, P to R is remaining normal, and P to R is also remaining normal. Whereas in third degree heart block, there is no correlation between P and R waves. So this is about third degree or complete heart block. This happens at the AV node. This is for the AV node. So this is about the heart blocks. So let's see a few ECGs to understand what is happening. So this is a ECG. As we can see, is it a sinus rhythm? Now we don't know because probably we are not seeing the regular P wave which should be before the QRS complex. It is in fact at a distance because QRS T and we see a P immediately. So distance between P wave and QRS is prolonged. So how much prolonged is it? It is, let's see, let's count. So starting of the P wave to starting of the QRS, it is like 10 plus 11 small squares. So if we see 11 into 0.04, so it is like about 200 milliseconds. So it is definitely prolonged. So more than 200 milliseconds, it is called as a prolonged PR. If it is a prolonged PR interval, this is known as first degree heart block. So this patient has first degree heart block. Most of the patients with first degree heart block won't have any symptoms. So let's go to the next slide. So this is second degree type 1 Venke batch. As I told you, PR is normal, PR is increasing, PR has increased, and then we see a P wave but no QRS complex. Then again the normal, again increasing PR. So if this kind of ECG you are seeing, it is known as a Venke batch ECG or a type 2 second degree AV block. So this is a Mobitz type 2. Type 1 is increasing PR interval, drop in QRS. Type 2 is where you are seeing P as normal. QRS, QQ or RR intervals are normal, but there is one wave which is missing. But P wave is seen. SA nodal block, you don't get to see a P wave. Here in AV block, you get to see a P wave because AV node is not functioning. So the rhythm or the activation is not being conducted to the ventricles, but definitely it is generated by the SA node. So we are able to see the P wave here in Mobitz type 2. And then there is an advanced type of AV block in which you get to see that there is a there are two P waves, but only one QRS. Again, two P waves, one QRS. So this type of block, we call it as advanced 2:1 AV block. Sometimes we get to see three P waves and one QRS complex. We will call it as 3:1 AV block. So let's see what is this now. What rhythm does it show? Does anyone want to contribute? What is this ECG? So let's see. We are seeing P waves. These are all P waves. So P waves are seen to be, here is also a P wave. See, a P wave is embedded in the Qrs complex. So P wave, P wave, P wave. So PP are regular. R to R waves are also regular, but there is no correlation between P and QRS, because here we see a P wave and QRS. Here we see there is a small distance between P and QRS. As here we see there is a more distance between P and QRS. So this is a complete heart block ECG. Also, if we find out the heart rate, it is going to be low. This is like 60-ish heart rate. So 60 heart rate here, if we take, it is definitely very low. So this is a complete heart block ECG. And these patients come with giddiness or sudden fainting attacks. So this is a very dangerous ECG. Normally we get to see it with inferior wall myocardial infarctions. This is the common presentation with inferior wall myocardial infarction. Patient comes with complete heart block. Sometimes patients don't even get chest pain. Why do patients come with complete heart block in an inferior wall myocardial infarction? That is because inferior wall myocardial infarction, in 60% of patients, it is the right coronary artery which supplies the AV node. And that's why if it is blocked before the AV node will branch, there's no blood supply to the AV node. And that's why we get this type of rhythm, that is complete heart block. So let's go to the next slide. Let's see what is this. So what do we see in this particular slide is, this is a different, we are moving out from the heart blocks, that is SA nodal block, AV nodal block. And this is something different where we see RSR pattern. Let's see the axis in this ECG. What is the axis in this ECG? Can anyone tell me? No one is contributing. I will like people to contribute.
Ma'am, the
So,
participants are mute. They can put their answers in chat
yes,
box.
I will like people to talk, because otherwise it feels like I'm talking to a screen, which I'm not very happy with. If anyone wants to contribute here, I'll be very happy to hear that. So we have to find out the axis in this particular ECG first of all. So what would be the axis? We find the most equiphasic QRS complex. So equiphasic is, it has an equal positive and negative arm. So in this we see that AVF has a equal positive and negative arm. In this we see if it is AVF, which is equiphasic, the opposite perpendicular lead to AVF will be lead 1. So lead 1 is having a positive node. It means it is at 0 axis. The ECG is at 0 axis. And there is a RSR pattern in lead V1. If RSR pattern in V1, if this duration of RSR is exceeding 120 milliseconds, then we call it as RBBB, right bundle branch block, and that is a complete right bundle branch block. So this is a ECG of a sinus rhythm, heart rate of around say 75, about 5 small squares, so 75 heart rate. We cannot say exactly that it is a left axis, but we will say it is a normal axis, but RSR pattern is seen. And here it will be denoted as small r, large S and large R. So RSR pattern in V1, V2. So this is a RBBB, right bundle branch block ECG. Okay. So let's go to the next slide. What do we see in this ECG again is we are seeing RSR pattern in V6, V5, V6, and it is a broad QRS complex. If we can see, it definitely is like 3 plus 2, so 5 large squares. So 5 large squares, it is definitely more than 200 milliseconds. So this is a complete left bundle branch block. If we see RSR pattern in lead V1, V2, it is right bundle branch block. If we see RSR pattern in V5, V6, it is a left bundle branch block. So very classic. we get to see these ECGs, and if they are associated with first degree heart block, or if they are associated with any kind of AV nodal block, then it becomes a bifascicular or trifascicular block. If it is a trifascicular block, it is definitely an indication for permanent pacemaker again. So we need to identify and understand these ECGs. So let's see what the next ECG tells us. So what do we see in this particular ECG? So it looks like a very normal ECG, sinus rhythm. We see the P waves. The best waveform or the best leads to see the P wave would be lead 2 or lead V1. So we are able to see the P waves in lead 2 very regularly coming before each QRS complex. So it is a sinus rhythm. The rate looks normal. So what is abnormal here is there is a small Q wave in lead 1 and lead AVL. If you can see, small Q wave and then R wave, small Q wave and then R wave. So if this is the pattern, this is called as left anterior fascicular block. We told you that the left fascicle divides into left anterior fascicle and left posterior fascicle. So this is, if you see a small Q wave, so this could be missed as a normal ECG if you're not very observant about the ECG. So small Q wave with left axis deviation if it is there. So do we have a left axis deviation? So for that, again, equiphasic Qrs complex, equiphasic would be a AVR. AVR is equiphasic. The perpendicular lead to lead AVR would be lead 2. So lead 3. So lead 3 is perpendicular to the AVR. So lead 3 is perpendicular and it is showing a negative complex in. So negative complex in lead 3. So the axis would be minus 30, minus 60. So if it is minus 60, definitely it is a left axis with Q in 1 and AVL. It is a LAFB, that is left anterior fascicular block. Let's see this next ECG, next slide. Here what are we seeing? Again, looks like a sinus rhythm. Everything looks normal. QRS is normal. It's a sinus rhythm. Every Q wave is preceded by a P wave. But what we see is a small Q wave in lead 2, 3 and AVF. Small Q. It is going down. Initial down segment is Q wave, small Q wave. So this is a left posterior fascicular block. So left axis with small Q into 3 AVF is left posterior fascicular block. Now going to tachycardia. So in tachycardias, there are, again, as I told you, is narrow QRS tachycardia and broad QRS tachycardias. So narrow QRS tachycardias, we have to see tachycardia, we say when the heart rate is more than 100. We have to see whether it is a regular tachycardia. It means regular tachycardia means whether it is coming regularly or whether there is a heart block. So if we see P waves are visible, then yes, then atrial rate has to be greater than ventricular rate. If it is yes, then it has to be atrial flutter or atrial tachycardia. If the atrial rate is not more than the ventricular rate, we have to analyze the R to P interval. If R to P interval is short, it goes to AVNRT. If R to P interval is longer than 70 milliseconds, it may be AVNRT is AV nodal reentrant tachycardia, AV reentrant tachycardia and atrial tachycardia. Here again, if we analyze, the R to P interval is long, that is RP is longer than PR interval, it goes into atrial tachycardia. We'll see the examples of this ECG, it will be much easier to identify. But we need to have this kind of background information when we are talking about a classification of a tachycardia or a SVT, specifically SVT. So let's see. Tachycardias are divided into narrow complex, that is less than 120 milliseconds, and wide complex more than 120 milliseconds. Most common narrow complex tachycardia would be a SVT. Now SVT, SVT is a broad classification. Any narrow complex tachycardia with heart rate of more than maybe 150, we call it as SVT. So in SVT, if it is a regular RR, we call it either maybe sinus tachycardia, AV nodal reentrant tachycardia, AV nodal reentrant tachycardia, atrial flutter, or atrial tachycardia. If it is irregular, it may be atrial flutter or atrial fibrillation. Now, wide complex tachycardia. Wide complex, as we already know, wide complex is generated only below the AV node. So if it is generated below the AV node, it may be regular. So it has to be something which is generated from the ventricle. So it has to be either a ventricular tachycardia, VT, monomorphic, or it is an aberrant conduction of a SVT. So this percentage SVT with the wide complex tachycardia is very less, though sometimes we get to see. SVTs are generally 95% of them will be a narrow complex tachycardia. 5% may be a SVT with aberrant conduction. 95% of broad complex tachycardias are ventricular tachycardias. So if the RR is irregular, we call it as ventricular tachycardia, may be polymorphic in origin. What do you understand by polymorphic? Means we are able to see different forms of Qrs complexes. So we will see few examples of them also. Or there could be again atrial fibrillation with aberrant conduction, or it could be ventricular fibrillation. So we'll see the ECGs. Now what is this ECG exactly? Let's see. So let's see in this ECG, what we are seeing is the, first of all, is the rate normal? No, rate is non-normal. It is definitely tachycardia because we see almost small 5 squares, 6 squares are there between two RR intervals. So if this is the thing, we see that the heart rate is about 250 to 300. Okay, so 250 to 300 of heart rate, and we see that there are Qrs complexes. Are they regular? Are the Qrs complexes regular? No, they are not regular. They are irregular. Here it seems like regular. Then there is an increased distance between RR segment. And are we seeing any P waves? Yes, we are seeing P waves before each Qrs. Are we seeing? Yes, we are able to see P waves. But what is very different is, see, look at the morphology of the P waves. Look at this morphology. Look at this pointy P wave. Look at this blunted P wave. Look at this inverted P wave. So we are seeing different forms of P waves with tachycardia, narrow complex tachycardia. So this ECG would be, because we are seeing multiple different forms of P wave, we would call it as multifocal atrial tachycardia. So this is a multifocal atrial tachycardia because we are seeing different morphologies of P wave. So whenever a P wave, because atrias may be firing from different focuses. So if they are traveling from different focus to the AV node, the morphology of the P wave is going to be different. So this is a multifocal atrial tachycardia. So let's see the next slide. What is this? Again, is this a sinus rhythm or whether it is a SVT? So if we can see that, yes, it is a narrow complex. It is a tachycardia. Very easily we can make out because we are only able to see like maybe 8 small squares between two RR intervals. So this is definitely a tachycardia. And because the rate, if we take, it is like, here we take it is 10, so 150, the rate is, heart rate is 150. Now we are seeing something after the QRS. What are we seeing is this is regularly coming before or after the QRS. And the distance R to P is small and P to R is long. So R P distance, R wave to P wave distance is smaller compared to P to R interval, right? This distance is smaller, this distance is longer, PR interval is longer. So this is a ECG of AV nodal reentrant tachycardia, AVNRT, which is the most common form of SVT, supraventricular tachycardia. Why supraventricular? Because narrow Qrs complexes. Why tachycardia? Because rate is about 150. So this is a supraventricular, we can call it as a broad spectrum supraventricular tachycardia, but if we go in detail, we can see that the RP interval is shorter than the PR interval. So this is a AVNRT ECG. Let's go to next slide. Now we'll go to wide complex tachycardia. So wide complex tachycardia, there's an algorithm which is given because we have to identify whether it is a VT, which is like 90 to 95% of the cases are VT with wide complex tachycardia, or sometimes it may be an aberrant SVT, that is 5 to 10% of the cases. So we have to, what do we have to see? We have to see AVR. So if there is a initial R wave, then it is a VT. If presence of initial R or Q wave is more than 40 milliseconds, then it is a SVT. Presence of a notch on the descending limb of a negative onset or predominantly negative QRS. If there is a notch on the S wave or Q wave, then it is a ventricular tachycardia. Otherwise, it would be SVT. So if there is a V6 to V1 is less than 1, then the ratio, that is, then also it is known as a, or we can diagnose it as a ventricular tachycardia. This algorithm gives you a broad idea that the sensitivity, if you check all the 4 criteria and if it falls yes, 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 then most likely it has to be a VT, and the sensitivity of this algorithm would be 96%, specificity would be 99%. So we are very sure, damn sure that it is a ventricular tachycardia. Why do we want to know whether it is a ventricular tachycardia or SVT? Because the treatment differs. If it's a ventricular tachycardia, the first treatment you will give is a shock, DC shock. So synchronized shock, if you could give to the patient with broad complex or wide complex tachycardia, they will immediately revert to normal. Otherwise, we might lose this patient. If it is a SVT, it may not revert with your DC shock. We'll have to try drugs like adenosine. So we need to be sure whether it is a VT or whether it is a SVT. But you will never be wrong if you diagnose a wide complex tachycardia as VT and give an initial DC shock. So it is a standard line of treatment. You see a broad complex tachycardia, you may not remember all these things, but wide complex tachycardia, patient comes with giddiness. The heart rate is like, I'll show you some ECGs of VT, but if you are seeing very broad complex tachycardia, heart rate is somewhere around 200, 300, you can easily give the patient a DC shock, synchronized shocks, 200 joules, and the rhythm might come back to normal and you might save a life. This is very important, especially for nurses, because you are the guys who will be first attending the patient. First person to attend the patient in the casualty, in the emergency department would be nurses. So it is very important to understand some emergency situations, like a complete heart block, like a ventricular tachycardia, like a SVT. So if we don't intervene in these patients, we'll definitely lose these patients. So it's essential to identify a wide complex tachycardia. That wide complex tachycardia, take it as ventricular tachycardia. If you happen to have time, if the patient's BP is stable, if patient is conscious, cooperative, then maybe you can take a time to think about whether it is SVT or VT. But if the patient is in shock, patient's BP is not recordable, patient is not conscious or semi-conscious, and ECG or even your monitor shows a VT, which commonly happens in cath lab whenever we are doing interventions. If there is a dissection sometimes, then these complications happen, that the patient goes into ventricular tachycardia. And if the patient has gone into ventricular tachycardia, we immediately shock the patient and revert the patient. That's how we save the life. So to the aim of the today's theme also, today's theme workshop also is to save a life, save a beat. So save a beat, this rhythm you need to identify. This rhythm has to be in your mind. What we see in this particular rhythm ECG is a wide complex tachycardia. We don't see a proper P wave or QRS. We just see wide complexes, and definitely the rate is more. So this is a ventricular tachycardia, and you're completely justified if you shock this patient. If this patient has come with hypotension, if this patient is brought to the casualty with semi-conscious state, shock this patient and the patient will revert and you will save a life. So keep that in mind, and this is a ventricular tachycardia. Now let's see what is this. This is again a form of a ventricular tachycardia where we are seeing the wide QRS complexes. Only difference in the previous and this ECG is you are not able to make it out whether the complexes are going positive or whether the complexes are going negative. So some leads we are seeing positive complexes, some leads we are seeing negative QRS complexes. So it is rotating. This is called as a rotating on itself. This is torsades de pointes. This ECG is a ventricular tachycardia with torsades de pointes. This is a terminal event. So it is a multifocal tachycardia, ventricular tachycardia, and in this again the treatment would be shocking the patient. So DC shock, defibrillator shock, 200 joules is justified again. So let's see. Now in this slide we are able to see how do we confirm that it is a VT. So if we want to confirm that it is a VT, we should see some fusion complexes, like we see a small P wave sometimes, or there could be a ventricular premature complex. If we are seeing this kind of complexes, like here, the RR is different. If we are able to see such kind of complexes, we will say that it is a ventricular tachycardia. So if this is a ventricular tachycardia, then we have to shock. This is a terminal event which we will see only probably on the monitor. It is very less likely you will be able to see this rhythm on the ECG. So this here we are seeing only broad QRS complexes. There is no PQRST. It is broad QRS complexes, and it is really broad and kind of, you cannot identify any waveform. So this is ventricular fibrillation. This is a terminal event. This is the time you need to keep the defib with the patient and shock the patient immediately to revert this patient. And even with like higher joules, whatever you can go up to, and you will have to give multiple shocks to revert this patient. And sometimes in spite of that, the patient we may not be able to revive. So this is a terminal event, ventricular fibrillation, broad QRS complexes, and these are not arrow pointed ones. These are blunted, and there is no duration. Some are broad, some are narrow. Even the peaks differ. So this is ventricular fibrillation, blunted, broad QRS complexes, mostly seen on the monitors. So we'll like to definitely make you guys aware of myocardial infarction, which is again one emergency which we get to see in the emergency departments. So there are, if we talk about myocardial infarctions, there will be two types, that is ST elevated myocardial infarction and non-ST elevated myocardial infarction. So what would be the difference between the two? In ST segment is elevated. How do we compare to ST segment 2? ST segment is always compared to the PR segment. So P to R segment is known as the isoelectric segment, and to it we will compare the ST segment. Now let's see in this ECG, we can see a ST segment elevation V1, V2, V3, V4. So there are 4 leads, contiguous leads, which are showing ST segment elevation, and the elevation is more than 5 to 7 millivolts. So it is like almost reaching 10 millivolts here. If we see this kind of ECG, this is also known as a graveyard sign. So you can understand how serious is this. It is a graveyard sign. If you're tombstone sign, you call it. See this tombstone sign. So tombstone or a graveyard sign, you call it, and this is the ST elevated MI. This is the anteroseptal MI. Along with ST elevation, we are also able to see ST depressions in lead 2, lead 3, lead AVF, lead V5, lead V6. So there is ST depression in all these other leads, and this definitely confirms that this is a ST elevated anteroseptal MI, because ST elevation is only from V1 to V4. Now non-ST elevated MI, coming to non-ST elevated MI, there won't be ST elevation. So what do we get to see is ST depressions. Only ST depressions are noted. So we can see V2, V3, V4, V5 and V6. There is ST depression. So we get to see this ST depression, and we send the blood enzymes, CPK-MB, trophi levels. And if they come positive, if the patient is having angina is a very specific type of pain. It is defined as a retrosternal pressure type of pain. So retrosternal pressure type of pain lasting for more than 20 minutes, take it as typical angina. Patient presents with chest pain. You see this ECG or this ECG, it is a myocardial infarction. It is an emergency because you can save the muscle, save the life if you act fast within the first golden hour. Golden hour would be first 60 minutes when the patient starts with chest pain. So if you could thrombolize patient with ST elevated MI. So even if sometimes the doctors are not available, or sometimes you see a patient where there are no facilities available, you can definitely thrombolize this patient and save this life, because this is tombstoning of ECG. So this tells that the patient is probably not going to make it if you don't intervene. In non-ST elevated MI also, patients become unstable, patient present with hypotension, severe chest pain, sweating, breathlessness, but we do not thrombolize these patients. These patients can be taken in cath labs. these patients also can be taken in cath lab if the facilities are available. So if facilities are available, we have to maintain the door to needle and door to balloon time. Door to needle would be when the patient comes to the hospital door to the thrombolysis needle. So when we are giving thrombolysis, that thrombolysis has to be within 30 minutes of the chest pain when it has started. The more delayed the thrombolysis would be, the more damage to the muscle, and maybe we might sometimes lose the patient. And in cath lab, if we want to take, if the facilities and cath lab team is available, we definitely should give the option for emergency angioplasty in this ST elevated MI patients. So if we give an emergency ST elevated MI patients a choice for emergency PAMI, then that door to balloon time, we call it, door to balloon time has to be 90 minutes, not more than 90 minutes. So we have to decide that this is an emergency. We have to alert all the teams, the cath lab, the doctor, the casualty team, and take decisions. So this is a very important ECG to understand, and this is N-STEMI or non-ST elevated MI. Now let's see what is this. This is again a tombstoning. You can see V2, V3, V4 is showing ST elevation, and there is ST depressions in lead 2, 3, AVF. So this is a anterior wall MI, acute anterior wall MI. Let's see the next one. So what is this? We see a ST elevation in lead 2, 3, and AVF. So if there is a ST elevation in 2, 3, and AVF, this is the inferior wall myocardial infarction. We see ST depressions in lead 1, lead AVL, lead V2, V3, and V6. So this is definitely, these ST depressions are known as reciprocal changes to ST elevation in lead 2, 3, and AVF. Now, if we want to take this patient in cath lab and we want to know whether this is due to the right coronary or left coronary artery, because we need to be ready with the catheters because this is an emergency situation. So on ECG itself, you can make out whether the right coronary or the left coronary may be affected or maybe 100% blocked. If it is 100% blocked, you get this ST elevated myocardial infarction ECG. So on this ECG itself, you can see that the ST elevation in lead 2 is less than the ST elevation in lead 3. So ST elevation in lead 3, if it is more, it is right coronary artery which is affected, causing a inferior wall MI. If we see the ST elevation in lead 2 is more than in lead 3, then it has to be a left coronary, left circumflex artery which is involved, which is 100% blocked, causing this kind of inferior wall myocardial infarction. So in this case, we have to definitely take the patient in cath lab, and because on this ECG we are able to see ST elevation more in lead 3, I will say that this patient has an inferior wall myocardial infarction with right coronary artery involvement. So I'll ask my technician to get all the right coronary catheters ready on my cath lab table so that we can minimize the door to balloon time and we can open the artery the faster and we can save that muscle and save that life. So I hope you have got a broad idea of what I was trying to say, and that's all. Thank you so much. If any queries, I am open for that.
Good morning, ma'am. I'm Sridevi. Can I ask one question?
Yes.
Ma'am, how do we differentiate posterior fascicular block and old inferior wall MI?
Posterior fascicular block.
Yeah, ma'am.
Inferior wall MI. Yeah. So this is the.
In both we expected Q waves in the three.
Posterior fascicular block. One very important thing is it is very rare to happen. What you get mostly is an anterior fascicular block. And if you get to see a posterior fascicular block, there will be a small Q wave in 2-3 AVF, what I already told you. If it is an old inferior wall MI, you will get QS pattern in 2-3 AVF. We'll have to see at the axis of the ECG. If axis is showing us a left axis with QS, then maybe it is possible. But it will be definitely difficult to identify in a case with inferior wall MI.
Okay. Thank you, ma'am. And one more, ma'am. The right bundle branch block, the RSR pattern in V1. And is it necessary to have W pattern like SRS pattern in V6? Or if only the M pattern in V6, can we diagnose?
Definitely, because we'll also have to see the other leads in lead 2, 3 ABF, how it goes. RSR pattern in lead V1, V2 is the essential or easily identifiable one, but there are multiple other things also associated, like right axis has to be there. RSR pattern can also be seen in lead 2, 3 ABF. So there are other clues to diagnosis. But I didn't wanted to make it too difficult because everyone should understand a broad idea. When you see a ECG, you need to like look at the ECG and identify it. Otherwise, you will be like having so many criteria, like we saw for the VT and SVT. There are multiple criteria, but thing is, you need to understand what is important to identification of a particular ECG, basically, which is more common. First view, you should identify and start with the treatment. That's what the theme would be, I will say. Yes, there are multiple criteria. If we go in, there are a lot of details given. And I will say, if you guys are trained to identify 90% of the ECGs, I'll be the happy person. I'll be happy.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, ma'am, for that wonderful session. I hope everyone will be able to identify.
I hope I'll be very happy to see that they identify the ECG and they are able to recognize and treat the patients on time. I'll be very happy to see that. Thank you so much.
Ma'am, there is one more question in question answer box.
Yes, please.
The question is by Viresh. Why it's very much important to observe lead 2 in ECG interpretation?
Why is it very important to observe lead 2? Because lead 2 gives us an idea about the PQRST. One, we see the P wave best in lead 2. That's why. So we know that whether it is a sinus rhythm or not. Second, when we take a long lead 2, we can identify whether it is a regularly irregular or irregularly irregular rhythm. So we need to identify those parts are very important. So long lead 2 is always taken with any 12 lead ECG to identify whether it is a regular rhythm, whether it is a irregularly irregular, whether it is a sinus rhythm, nodal rhythm. So there are so many things which come to our mind, whether the P wave, if it is a broad P wave, like more than 2.5 squares, then we call it as a P mitral, P pulmonale. So lead 2 gives us a very broad idea of a ECG. So rhythm strip we always take for lead 2. Anything else?
Thank you, ma'am.
Thank you so much.
Thank you very much, ma'am, for being there with us. We will move ahead with the next session now. Now let's welcome the next resource person. I would like to welcome Dr. Pakodi Arjuna ma'am, who is a PhD in medical surgical nursing. She is reader and HOD of Sri Ramachandra Institute of Higher Education and Research, Chennai. She is a member of TNAI, Medical Surgical Nursing Society of India, Nursing PhD Society. She has secured Tirumati R. Rajam Gold Medal for Best Outgoing Student in medical in her MSc Nursing. Served as an inspector for Indian Nursing Council, recipient of Gold Coin for a decade of dedicated service in nursing from the Chancellor of Sri Ramachandra University. Over to you, ma'am.
warm good morning to all. And I bring greetings from Sri Ramchandra Institute of Higher Education and Research. Hope I'm audible.
Yes, ma'am.
Thank you. So before starting this session, let me thank the organizer, Dr. Prabha K. Dasila, Professor and Director, Dr. Kunchitra Madam, Vice Principal, Organizing Secretary, Mrs. Ferkancia Jubilson, Assistant Professor from NGM New Bombay College of Nursing, NGM Institute of Health Science. So for giving this opportunity to be a resource person, and the college has chosen the right theme for national webinar on rhythm recognition, save a beat. So let me start with my slide. Give me 1 second. Are you able to see my PPT?
No, ma'am.
Now?
Yes, ma'am.
Okay. Thank you so much. Let me put it in a slideshow mode. I'm very happy that the participants are like a mixed group, starting from second year BSc nursing students, third year BSc, and MSc first year, second year, including faculties. So it is very difficult to cover the different level of the participants. Anyway, I will try my maximum. And the previous speaker, Dr. Shilpa Madam, has taken in detail session how to identify the rhythm. So it is going to be easy for me to focus more on the management. So because the topic given for me is also management of these arrhythmias. So my presentation for this next 1 hour is on definition of cardiac dysarrhythmia, risk factor and etiology of cardiac dysarrhythmia, types of cardiac dysarrhythmia, clinical manifestations of cardiac dysarrhythmia, and various diagnostic studies, collaborative management of cardiac dysarrhythmia. So these are all the aspects I'm going to deal in detail. So to start with, still in India, not only in India, the worldwide, the leading cause for death is the cardiovascular disease, especially ischemic heart disease. And ischemic heart disease has many complications. So as a nursing student or as a nurses, we should be familiar and we should have skill in identifying this condition before. And because prevention is very important, so the topic given or allotted is also very important. So the arrhythmia is, all of you know, it is a change from the normal. Normal rhythm is the normal sinus rhythm. Arrhythmia, in case any change from the normal electrical impulse, then it is called arrhythmia. It may be too fast, or it may be too slow, or it may be irregular or erratical. So that is called as arrhythmia. So when the patient is having arrhythmia, the treatment, there are different varieties of the treatment. Most of the arrhythmias even doesn't require any treatment at all. We can manage. It will subside on its own. But some of the important arrhythmias require the medication, and some arrhythmias require the lifestyle changes, and some even extreme condition it requires invasive therapies as well as the electrical devices or surgery. So there are different treatment modalities are available for each type of the arrhythmias. So we are going to see in detail. So the normal rhythm, so in the previous slide itself I told, and even the previous speaker also has explained in detail, the normal sinus rhythm is the usual heart rhythm. Okay, so that starts from the SA node or the sinoatrial node. If you see the rate, it varies from 60 to 100 beats per minute. If the heart rate goes less than 60, then it is also called as dysarrhythmia, or if the rate goes beyond 100 beats per minute, that is also considered to be dysarrhythmias. So dysarrhythmias, any disorder in the heart rhythm. So this can be due to either disturbance in the electrical cycle of the heart. Okay, so we are going to see in detail about the cardiac conduction system. Cardiac conduction system very briefly, because management we will focus more. the impulse initiates normal pacemaker from the SA node, and from the SA node, the whole atrium is contraction, and from that it goes to AV node, and from AV node, bundle of his, and through Purkinje fibers, the ventricles are going for the contraction. So this is how the normal cycle completes. So in this normal cycle or in this sequence, if any problem, then it can lead to change in the rhythm or change in the heart rate. Okay, so we will see in detail. So interpret. So again, I'm not going to take in detail because the previous speaker has taken, but you should know what are all the different components in interpreting the normal sinus rhythm or the characteristics of the normal sinus rhythm. Either the ventricular or the atrial rate, it should be between 60 to 100 beats per minute, and the rhythm, if you see, it should be regular rhythm. Okay, it may be a atrial rhythm or ventricular rhythm, but it should be a regular rhythm. Same way the Qrs complex on the duration also should be normal and regular and P wave. So before each Qrs complex begins, there should be a present of the P wave. It should be consistent and regular. So that is a normal important characteristics. And about the PR interval is also it is between the 0.12 seconds to 0.20 seconds. This is the normal PR interval. In case of dysarrhythmias, this interval seconds may increase or decrease. So to interpret that, we should be aware about the normal PR interval. And same way, the P as well as the QRS ratio, it should be equal. So for one P wave and one QRS, it should be equal, but to some condition, it may not be the 1:1. So it may differ. So this is the normal sinus rhythm or the important characteristics of the normal sinus rhythm. Before going to in detail about the risk factors and the etiology, so what are the important mechanisms? How this dysarrhythmias takes place? How it leading or causing the dysarrhythmias? For that, we should understand the important properties. So there are 4 important properties. So automaticity, conductivity, contractility, excitability. So these are all the different properties. So in this, especially the automaticity or conduction and re-entry of the impulse. So these are the 3 important factors or the mechanism responsible for causing dysarrhythmias. We will see briefly about this. So about the automaticity. So in automaticity, it is enhanced from normal to the abnormal due to the during the diastolic depolarization, and because of this spontaneous depolarization develops during the diastole period. So the blood filling into the left ventricle will be decreased, and it can cause the decreased cardiac output and other sequences due to this. Some of the common automaticity stimulants so are called like excess catecholamines, or some situations it may be due to the physical stressors or due to other factors, it can lead into hypoxia. So decreased oxygen level, it may be due to ischemia and some of the other disturbances, not other than the cardiac conditions also. So non-cardiac condition may be due to acidosis or ischemia and other metabolic disturbances. All this can cause changes in the automaticity, and that is one of the important mechanism leading into the dysarrhythmias. Same way, the other mechanism is called the re-entry. So re-entry is also one of the important mechanism for dysarrhythmia. This is because of the changes or the problem in electrical circuit within the heart. So this also in detail we are going to see, and we are going to discuss which are all the types of the arrhythmias are caused due to this. And the other mechanism are due to the triggered activity. So due to the triggered during this cardiac conduction depolarization, after the initial depolarization, so it is not regular. So 2 forms. So it is not in equal interval or regular interval. So either it occurs early or it may occur in the late. So this is also one of the important mechanism causing this dysarrhythmias. So we will see in detail about the etiology or the risk factors. First, we will see some of the etiology or risk factors under the automaticity. So automaticity, previous mechanism also we have seen. Important risk factors related to the cardiac conditions are myocardial ischemia. So when the myocardial cells are not getting adequate blood supply, and that can lead into the dysarrhythmia. So even once patient is diagnosed with MI, one of the important complications of MI is the dysarrhythmia. So as a nurses, we should be responsible in assessing ECG continuously even after the diagnosis of myocardial infarction to prevent the complication of the dysarrhythmia. Same way, decreased left ventricular function. So if the left ventricular function is decreased again, the ejection fraction will be decreased, and that causes the dysarrhythmias. And some of the valvular heart disease and electrolyte imbalance, especially sodium and potassium electrolyte imbalance, hypoxia, or even as a side effect, not only due to the cardiac condition, even some of the drugs also can cause this dysarrhythmias, especially the digitalis toxicity. When the person is on digoxin for longer duration, maybe for due to some other cardiac condition, important side effect of the digoxin is the digitalis toxicity. If the patient is going to this side effect of digitalis toxicity, then the patient is at risk to get any of the dysarrhythmias. And same way the atropine. Okay, so even though atropine is used to increase the heart rate, but that drug is also can cause the dysarrhythmias. So these are some of the risk factors leading into the automaticity, and some of the other important risk factors related to the conduction disturbances are few valvular heart disease, or the patient undergone some of the valvular heart surgery, or the inflammation of the AV node, and again some of the electrolyte imbalances and digitalis toxicity, or beta blocker. Again, beta blocker is one of the anti or a dysarrhythmic agent, but still that also can cause the dysarrhythmia. And MI, already we discussed, especially the inferior type of the MI can cause this conduction disturbances and lead into the dysarrhythmias. And the third mechanism is re-entry of the impulses. Common some of the risk factors are again myocardial ischemia or anti-dysarrhythmic medications, and myocardial fibrosis and the bundle branch block. So these are some of the risk factors for re-entry of the impulses. Okay, so we have discussed in detail about the risk factors or the etiology. So remember that not only the cardiac conditions can lead into the dysarrhythmia, even non-cardiac conditions, some of the triggering factors, even some psychological disturbances or physiological stressors or some drugs other than the cardiac condition also can lead into this dysarrhythmias. Hope you are all clear with the risk factors and etiology. So we will move on to the rhythm. Already we have discussed the normal characteristics of the sinus rhythm. Once again, to reinforce that normal characteristics or descriptions of a normal sinus rhythm. So normal sinus rhythm description, it is the atrial and ventricular rhythm. So the rhythm should be regular. In each cycle, it should be regular. And same way, the rate, if you see, it should be between 60 beats per minute to 100 beats per minute. If it is less or more, then it can lead into dysarrhythmia. And the same way, the PR interval and the QRS width also should be within normal limits. And even we have seen P and the P ratio and the QRS ratio, it should be 1:1. So these are all the normal. And previous session, in detail, it was dealt on the normal Ecg and the different rhythms. So you should be able to interpret this normal sinus rhythm. And now we will see the types. So in the dysarrhythmias, there are different types are there. Already we have seen the mechanism. So based on the mechanism, some dysarrhythmias can be originated from the SA node. We have seen the conduction system. Some dysarrhythmias can be originated from the atrial. So based on the location, these rhythms are categorized or classified into different types. So we will see what are all the rhythms originating from the SA node. So there are three important: sinus bradycardia and sinus tachycardia and the sinus arrest. So by the name itself, it is called the normal rhythm only. Sinus is the normal rhythm. Only here the change is the rate, heart rate. So bradycardia, it will go less than 60, and tachycardia, it will go more than 100. Otherwise, there are no other changes. It is regular interval, and all other characteristics are normal. So out of this three, these two are very commonly seen, that is sinus bradycardia and sinus tachycardia, whereas the sinus arrest is similar to the previous one. And the rhythm originating in the atrium. So from the atrium, again, there are three important dysarrhythmias: atrial flutter, atrial fibrillation, and paroxysmal supraventricular tachycardia. So again, this atrial flutter and atrial fibrillation, these are very common because this dysarrhythmia management, in the introduction I said, some of the dysarrhythmias doesn't require any treatment, it will subside on its own. Only we need to monitor whether it is repeatedly recurring or what is the patient condition. But here atrial flutter and atrial fibrillation definitely needs the management, important management, we will discuss later, under this originating from the atrium. Then other types of the dysarrhythmias originating from the atrioventricular junction. From the atrioventricular junction, premature junctional complex, and the junctional escape rhythm, and the junctional tachycardia. So when compared to the sinus and the ventricular, the origin, this is very less common, and rhythm originating in the ventricle. So again, this is very important. Premature ventricular contraction and ventricular fibrillation and the ventricular tachycardia. And Dr. Shilpa Madam has taken in detail, even she has included management for VT, VF, all that in detail. So it is one of the common and very important rhythm. As nurses, we should know the emergency management for this abnormal rhythm, which is originating from the ventricles. Hope the BSc students mainly understood about the different types of the dysarrhythmias, which is originating from the SA node and from the atria and from atrioventricular junction and the ventricle. So these are all the different types. So now we will see, before going to see in detail each the abnormal dysarrhythmia and what is the cause and the management, to see in detail. Overall, we will see what is the dysarrhythmia clinical manifestation. Mostly this patient will come to emergency department or in the ICU. So as a nursing student or as a nurses, we should be able to identify when we do the assessment or the physical examination or by collecting history. That is very important. So what are all the clinical manifestation the patient will exhibit due to this dysarrhythmia? Already I told in the mechanism, if the left ventricle ejection fraction is low, and again cardiac output will be decreased. Okay, so because of this decreased cardiac output and the stroke volume also will be decreased. So due to this, the patient will experience very common clinical manifestation as the palpitation. This is very important. The patient will come to ER and say that I have palpitation. Okay, so that is very commonest the symptom. The patient will come to ER, and other than this, the other clinical manifestations are dizziness. Okay, so palpitation, dizziness, and syncope. So syncope, again we should be able to differentiate from the vertigo. So syncope and pallor. Patient may mimic the symptoms of chest pain, like extreme diaphoresis or profuse sweating, diaphoresis, and altered level of consciousness. Patient may be unconscious or altered restlessness, agitation, lethargy. Even patient can go up to the coma state, and decreased urine output. And patient, because of the hypoxia, decreased stroke volume, and decreased cardiac output, patient may experience the shortness of breath or the dyspnea or breathing difficulty. And again, because of decreased blood supply and decreased cardiac output, the patient will experience chest pain and orthopnea and paroxysmal nocturnal dyspnea. Some of all this clinical manifestation may mimic the clinical manifestations of heart failure, because heart failure is one of the common the condition where the patient may experience the dysarrhythmia. So if you see shortness of breath, chest pain, orthopnea, and paroxysmal nocturnal dyspnea, even hypotension, decreased urine output, diaphoresis, all this mimic the clinical manifestations of heart failure. And apart from this, the swelling of the extremities, edema, and sluggish capillary refill due to the decreased blood flow or decreased cardiac output. So these are all the common clinical manifestation when we do the physical examination or when the patient is admitted in ER, we should be able to assess. So then only we will be able to proceed with various diagnostic tests and start the treatment, because this treatment we cannot take longer time. Okay, so within few seconds we should be able to identify this abnormal rhythm, and immediate initiation of the treatment will be able to revert back to the normal sinus rhythm. That is the main goal. If the treatment is delayed, then it is difficult to revert back to the normal sinus rhythm. So we should be able to know in detail about the clinical manifestations of the dysarrhythmias. So now we are clear with the some of the clinical manifestations, and we will see the diagnostic evaluation of the dysarrhythmias. So always as nursing students, the assessment starts with the history collection. Assessment includes a history collection, physical examination, and some of the diagnostic tests. Some diagnostic tests may be invasive diagnostic test or non-invasive diagnostic test. So we will start with the history collection. So when the patient comes to the ER or even in the ward, if you identify some rhythm, then very quick history. We cannot spend more time in collecting history if the patient is unstable. So if patient is stable only, we can collect these details. So history regarding the onset and duration, associated clinical manifestations or aggravating factors, and some of the relieving factors. Already you know the history collection format. Okay, PQRS format, provocating factors and relieving factors, associated factors, all that. So based on that, the history collection format, only the focused history about, suppose patient says that I have palpitation. So related to palpitation, we should ask. And or if patient is telling about the chest pain, so related to chest pain, all this aggravating factors, relieving factors, and associated symptoms, all this to be collected based on the important clinical manifestation. So focused history is very important. And other than that, we have to collect about whether patient is a known having cardiac conditions. Okay, maybe known conditions of ischemic heart disease or any other previous cardiac history also to be assessed, because any known cardiac condition, already they are under risk for the dysarrhythmia. So we have to collect about the past history also, and the hospitalization. Whether patient was hospitalized before for any other dysarrhythmia management or for any other cardiovascular disease condition. And apart from the medical history, even the surgical history also to be collected. Surgical history again, allergy and medication apart from surgical history, because before starting the medication, we have to ensure whether patient is having any allergic to particular medications. So that is most important. And if known patient of some of the cardiovascular condition, whether he is on regular medication, if known, what is the name of the medication, and about the dietary habit, whether patient is mixed diet pattern or taking non-vegetarian, and the cholesterol level, all that dietary habits, and the social habits, important social habits like the smoking and alcohol, and other family history, because some conditions, cardiac condition, the important risk factors are the family histories also. So we have to ask, in the family any member is having known conditions either of dysarrhythmia or of any of the cardiovascular conditions. So these are very brief history but important. This history will help the nurses or the physician to rule out or to diagnose the dysarrhythmias or to decide what further investigation is mandatory. So this is about the history collection and the physical examination. Again, physical examination, we have to do quick head to foot examination, but we should focus more on the systemic examination. So since this cardiac system is involved, we should focus more on the cardiac examination. So mainly this cardiac examination, again using the different physical examination findings like inspection, palpation, percussion, and auscultation. In previous assessment itself, we have seen the other methods of the physical examination findings like patient is restless and altered level of consciousness, dyspnea. All this can be observed by using the inspection. Okay, and the palpation and percussion is not having that importance, and auscultation. So again, auscultation, we have to auscultate for the heart sounds, whether it is the normal heart sounds, and the 5 important location, 5-point heart auscultation to be done, and we have to determine the rate. Already I told that the rate should be between 60 and 100 beats per minute. If the rate goes less than 60, then it is a bradycardia, or if the rate goes more than the 100 tachycardia, the tachydysarrhythmias or bradydysarrhythmias. So we have to auscultate for the heart sounds, whether it is a normal heart sounds or whether it is the abnormal heart sounds. Then we have to determine the heart rate, whether it is the regular rate or is it irregular. We have to auscultate for 1 full minute and see the rate. Okay, so we should not just auscultate for 15 seconds and multiply into 4 like that. So we have to count for 1 full minute. Then only we will be able to know whether the beat is regular or irregular or any missing. All that can be absorbed by auscultating continuously for 1 minute and check whether the heart sound is regular or any abnormal murmur heart sounds. So this is about the physical examination. Once the history and the physical examination is over, then relevant physical examination, because some of the nurse practitioner is also attending this. I know Sri Devi is a nurse practitioner and many nurse practitioner students. So as a nurse practitioner, you should be able to know what are all the diagnostic tests to be ordered in case of emergency. When the patient is reported to the ER, what kind of additional investigation other than the history and physical examination, what are all the relevant diagnostic tests to be ordered? Some of the diagnostic tests, ECG and all, even nurse practitioner, they can order and they can take, interpret, and they can start the management. So one of the very important, any cardiovascular condition, important diagnostic test is the ECG. So we have to take the 12-lead ECG recording in the ER itself. We have to monitor the ECG, and other than that, especially with regard to the dysarrhythmias, Holter monitor, because one time if we take the 12-lead ECG, then it is very we may miss the dysarrhythmias. Okay, that point of time, if the dysarrhythmias are not there, then it is very difficult to identify. So to rule out, if patient is normal, stable, maybe to rule out for a longer duration of the dysarrhythmia, we can go further for other diagnostic tests like the Holter monitor. So Holter monitor, even BS students would have studied about the Holter monitor for 24 hours. Okay, leads will be placed and it will be recorded, and we have to take the print of the ECG for 24 hours. So some of the important instructions to be given for the patients to monitor the activity, so that we can correlate when the heart rate was low or which activity, like activity log they have to maintain, and but they can proceed with the daily regular activities, and that will be useful in identifying the abnormal rhythm. So it is called a Holter monitor. So it is like a cardiac rhythm can be documented for 24 hours. But again, even with this Holter monitor, okay, other than this, sometimes it may miss out the dysarrhythmias. So in that condition, next advanced step is called the event monitor. So event monitor means it is not only the 24 hours maintaining the activity log. Other than that, event monitors, when the patient feels the palpitation, or when the patient feel dizzy, or when patient feels difficulty in breathing or pain, okay, some change in the normal heart rate, then that condition the patient can on this and the patient can record. Okay, so that later it can be viewed and it can be sent even through mobile also to, if like a telemetry. Okay, so and we can interpret and we can identify. So without missing any dysarrhythmias from the Holter monitor or from the 12-lead ECG, the event monitor will be more helpful in identifying or diagnosing the dysarrhythmias. Okay, so that is the indication for event monitor. So do not experience the dysarrhythmias within this 24 hours of recording period. Okay, so there we can go for the event monitor. You can see the monitor looks like or similar like a Holter only. You can see in this picture there are different types of the Holter monitors here. The patient can fix the leads and the patient can monitor, and the patient can maintain the diary. And the same way, this is like a event recorder. So the patient is having the control. Okay, they can on and off, and later it can be interpreted. So this is also one of the important monitor useful in diagnosing the dysarrhythmias. other than this Holter monitor, ECG, event monitor, other important diagnostic evaluation is the invasive electrophysiological studies. Okay, EPS, it is one of the important the diagnostic test. Even this is useful during some therapeutic intervention also. So this is it will be done in the cath lab, and it will help in identifying the dysarrhythmias focal point. Where is the conduction disturbances, whether it is in the atrium or whether it is in the ventricle or the bundle of his or the bundle branches, or where is the location point of the conduction disturbances will be accurately evaluated by this diagnostic test is called electrophysiological studies or EPS. Okay, so now we have discussed these are the related diagnostic tests for the dysarrhythmias. Other than the dysarrhythmias, these are all the diagnostic tests. There are other diagnostic tests, again depends on the etiology. We have seen some of the common cardiac etiology like MI and cardiomyopathy or heart failure or valvular heart disease. So if the patient is a known condition or having this cardiac disease, then we have to take relevant diagnostic test if needed, okay, to identify. Other than that, it is only to identify the dysarrhythmia. These are the common diagnostic tests. So once all the diagnostic test is done, now we have collected the history and we did the complete physical examination and in detail of cardiovascular system examination, and we have taken important diagnostic tests. Based on the result of those details, then we should plan and to proceed with the management. Already we said this dysarrhythmia is one of the important emergency condition. Okay, so emergency management is needed. So when patient is admitted in ER, okay, so immediately during the triage period itself, we have to assess the following findings. Okay, like the rate, whether the rate is regular or irregular, and rhythm is regular or normal sinus rhythm, or what is the rhythm we have to assess. And the BP, if we check, either the patient will be having hypotension or hypertension, definitely SpO2 will be decreased than the normal, because hypoxia is one of the common the clinical manifestation we have seen. So SpO2 will be decreased and the patient will experience a severe chest pain, similar like a MI pain. So chest pain, it may radiate to the other area like the neck or the shoulder pain. Okay, so jaw. So these are the important the characteristics of the pain also to be assessed in ER. Then patient may come with a syncope, dyspnea, restlessness, that is also to be observed. Even sometimes patient may tell that numbness or a tingling sensation in the arms, maybe sometimes due to the again the dysarrhythmias or the conduction disturbances or electrolyte disturbances, and even sometimes patient may go into the shock, hypovolemic shock, hypoxia, hypovolemic, or sometimes patient can go into the hypervolemia also. So if patient is going to the hypovolemic shock due to the huge blood loss or hemorrhage, then patient may have cold clammy skin, diaphoresis, restlessness. There are other important assessment findings as a nurse we should be able to do in the ER. So once the assessment is over, then initial intervention. Any patient that comes to ER, the important nurse's responsibility is to do the triage. So during the triage process, we have to check the ABC. Always remember that airway, breathing, and the circulation. So quickly assess the airway, breathing, circulation. Based on this assessment, we have to categorize the triage. Okay, and during this primary survey itself, assessing the ABC, we have to administer the oxygen because patient is experiencing the hypoxia. So administer oxygen. Then we take the baseline vital signs. It is very, very important. Baseline, basic vital signs starting from temperature, pulse, respiration, BP, and SpO2. That will be considered as the baseline. So later, immediately a few seconds, the patient vital signs may change or deteriorate. So we should be able to compare with the baseline and will be useful in diagnosing or deciding the treatment. So obtain even 12 lead ECG also is the baseline ECG. So take baseline 12 lead ECG and baseline vital signs and baseline hemodynamic parameters. Here when patient is admitted in ER, hemodynamic parameter is very, very important. Okay, and especially the cardiac monitor is very important. All ER the facilities will be having the hemodynamic parameter. including the cardiac monitor. So we have to continuously monitor the ECG, and we have to monitor the BP and SpO2, MAP, okay, and saturation. All these values to be monitored from the cardiac monitor, and identify the underlying rate and rhythm, and identify the dysarrhythmia using the different diagnostic test report and the ECG findings. And once they identified, then we have to start IV access. Any patient comes to ER again, after starting the oxygen and positioning the patient, important the responsibility of the nurse is to start the 2 IV line. Okay, then obtain the baseline lab investigation. We cannot rely only on the ECG or the Holter monitor. Okay, so we have to take some of the again baseline blood investigation. Depends on the, if patient is a known case, then we may need to take the cardiac biomarker. Okay, if not, definitely for all the patient we have to check the complete blood count. And in the dysarrhythmia mechanism, we have seen electrolyte imbalance or the electrolyte disturbances, mainly the potassium and electrolyte. So we have to check the electrolytes level, and we have to check the CBC and biomarker. If patient is known like heart failure, then we have to check the BNP and other cardiac biomarker to be taken. So these are all the important initial intervention. So by implementing this initial intervention, we should help the patient to revert back and help the patient to maintain the normal hemodynamic. Still, if patient is not maintaining the hemodynamic stability, then the treatment should further continue. Depends on the type of the dysarrhythmia. All this initial intervention and assessment finding is common for any dysarrhythmia, but the particular treatment we will focus according to the each type of the dysarrhythmias. So again, under management for the dysarrhythmias, overall dysarrhythmias, we will see there are other management also other than the previous what we have seen the initial intervention. We will see all the management. Then we will see, it will be easy to understand for each type of the dysarrhythmias. So another important management is called vagal maneuvers. So vagal maneuvers, that is again very commonly used terms. Vagal, to stimulate the vagal nerve, or the technique is called vagal maneuvers. Okay, so by stimulating this vagal nerve, what will happen? The cardiac, the conduction system will be stimulated so that it helps in regularizing the normal rhythm. So if patient is having tachydysarrhythmias, then the rate will come down. Okay, so that is the purpose of doing the vagal maneuvers, and the vagal maneuvers has again different methods. One of the common method is called the carotid sinus massage. Carotid sinus massage, it is also one of the important procedure can be done in ER itself by the physician. Okay, so but it is very important during the facility should be available like ER. We cannot do it in the other settings. So carotid sinus massage, we should tell the patient and explain, and we should not, again important point we have to remember, both the side carotid sinus massage should not be done. Only one side we have to do, and whatever the side you are planning to do, right or the left side, ask the patient to turn away from that side. Okay, right side means ask the patient to turn to the left side slightly, and the massage, before giving massage, we should check the ECG. Okay, that is very, very important. Before massage and immediately after massage to see whether it is reverted back to the normal rhythm or not. So this massage, again, the duration, it should not, only it is 5 seconds. 5 seconds means you can imagine, very quick. Just the palpate the carotid, the sinus, and give this quick massage for 5 seconds. That's all. Okay, it should not go beyond 10 seconds. Okay, so remember that. So few seconds only, and again take the ECG and check whether change. Okay, and when this procedure is done, we have to monitor the patient ECG continuously, and all the emergency equipments, crash cart should be ready, and we have to document. Okay, all resuscitative equipment or crash cart should be ready, including the defibrillator and other equipment should be available. Because of the pressure, if it goes longer duration, then it can cause again further disturbances. So to manage that, we should be ready with emergency equipments, and we need to monitor the vital signs immediately after this cardiac sinus massage. and we have to monitor the cardiac rhythm and the level of consciousness following the procedure. That is very, very important. So this is called the cardiac sinus massage. It is one kind of management under vagal maneuvers. Okay. And the next important vagal maneuvers is called Valsalva maneuver. So Valsalva maneuver means here we should give instruction to the patient, or we can stimulate the gag reflex. All of you know how to check the gag reflex. So by stimulating the gag reflex, we can check the vagal, we can stimulate the vagal response. So again, that also helps in reverting back to the normal rhythm. Okay, so a patient can bear down like how the during bowel movement like that, bearing down will stimulate the this Valsalva maneuver. And but during this procedure also again we need to monitor the rate, rhythm, and all vital signs to be monitored, including the blood pressure and cardiac monitor. Already I told any of the procedure or even once patient come to the ER with dysarrhythmia, it is our responsibility to connect the patient to the cardiac monitor and continuously monitor the patient for any change in the rhythm. And during this the Valsalva maneuver, sometimes patient may feel like vomiting. So in case of gag reflex is stimulated, sometimes patient may go for aspiration. So we have to prevent the aspiration by positioning. And if patient feels vomiting, then we should provide a kidney tree or NSS basin for in case of vomiting. And again, we should keep all emergency resuscitative equipments like defibrillator and other medication equipments should be ready during this Valsalva maneuver also. So under this carotid massage we have seen, and Valsalva maneuver we have seen, and anti-dysarrhythmic medication. Other than this, medication is very, very important. Okay, so anti-dysarrhythmic, most of the dysarrhythmias can be managed by this anti-dysarrhythmic medication. And it has different classifications of the anti-dysarrhythmic medication. This medication mainly suppresses the dysarrhythmia and helps in normal electrical conduction of the heart. So very common classification, there are 4 classifications are there, but still many drugs are under trial. Even class up to 5, 6, 7 are also there, but it is under trial. But very commonly used is the class 1, class 2, 3, and the 4. So class 1 anti-dysarrhythmic are the sodium channel blockers. Okay, and class 2 are the beta blockers. Class 3 are the potassium channel blockers. And class 4 are the calcium channel blockers. So these are all the important classification of the dysarrhythmic medications. Again, it has got further classifications. Okay, class 1 itself, it has got class 1A, 1B, 1C, like, okay, so 1A again, sodium channel blockade or blockers, and it helps in prolonged repolarization, shortened repolarization, and a little effect on the repolarization. All these comes under the first classification of the dysarrhythmic medication. Commonly used drugs are quinidine, propionamide, okay, lidocaine. So these are all the phenytoin, and other even common drugs are fictinidine. Okay, and these are all the common drugs in the class 1. Class 2 are the beta adrenergic blockade. Commonly used are propranolol, desmolol. Class 3 is the sotalol, amiodarone. Again, amiodarone is very commonly used drugs. And class 4 is the calcium channel blocker. Commonly used are the verapamil drug or the deltiazine. So again, with regard to the medication, the loading dose, okay, immediately during emergency, we should give the bolus dose or the loading dose, and I think the dose will be tapered and it continuous infusion to be given. So according to the classification of the dysarrhythmias and according to the dysarrhythmia type, this dose will differ. Like adenosine means the loading dose will be 6 to 18. Okay, milligram rapid bolus we have to give. Okay, that like that, each drug has got the different dose. In case of atrial fibrillation or supraventricular tachycardia, amiodarone will be given. So again, the loading dose will be 15 milligram per minute. Okay, for the 10 minutes. Then the dose will be changed to 1 milligram per minute for 6 hours. So maintenance dose will change. So like that, there are different classification of the dysarrhythmias. So because mostly the dysarrhythmias are managed by this drugs, our nurses' responsibilities are very, very important responsibility. Okay, so class 1, because we are the one going to administer based on the doctor's order the drugs. So we have a lot of responsibilities while administering the drug, especially while administering the class 1 drug group of the drug. We should check for the heart failure and check the BP, okay, and the QRS duration. Monitor the ECG for prolonged QT or QRS, and in case if we are giving N-acetyl procainamide to be monitored. Okay, then class 1B we have to assess the CNS changes or tremors. Whether patient is altered level of consciousness, and lidocaine means we have to decrease the lidocaine dose in case if patient is a known cardiac or the liver dysfunction. And one class 1C classification drug, we should be very cautious when patient is having a chronic kidney disease patient. Avoid using in patients with the structural heart disease like coronary artery disease or the heart failure. Same way, classification 2, we have to monitor the important parameters like heart rate, okay, and the PR interval, signs and symptoms of heart failure, blood glucose level, if patient is a known diabetes mellitus, okay, and class 3, we have to especially important is PFT. So especially for atrial fibrillation, we have to check the pulmonary function test and monitor the QT duration and continuous ECG monitoring and the renal function. Class 4, we have to check the heart rate and the pulse rate and the BP. Okay, so all this. Important point is do not crush the sustained release medication. So that is very important. And cardioversion. Okay, so this is about the drug. Okay, then about the cardioversion. So in cardioversion, it is the synchronized. All of you maybe must have heard about the cardioversion and defibrillation. Cardioversion, if the patient is stable and hemodynamically stable, then we can go for the cardioversion, synchronized compress shock to convert the abnormal rhythm to the stable rhythm. But starting with the lower amount of the energy to be used than with the defibrillator. Okay, defibrillator is the synchronized one. When R wave comes, then the defibrillator shock to be given. That is the difference between the cardioversion and the defibrillator. So defibrillator is not the synchronized. And about the cardioversion again. So electrical cardioversion and the defibrillation, these are the commonly used procedure in managing the patient with cardiac dysarrhythmias. Okay, this cardioversion procedure, when we do, the energy level required or low. Okay, and it is synchronized to Qrs complex. Whereas defibrillator, it is asynchronous and it requires the higher level energy. Okay, that is very important points you must remember. And non-emergency electrical cardioversion is the ideal one. Planned cardioversion is the ideal one, having controlled environment, and even we can administer the anti-dysarrhythmic medication, and then we can plan for the cardioversion, having all equipments ready. All this to be mandatory before starting the cardioversion procedure at bedside. Okay. Then other points we must remember during cardioversion, it is similar like a defibrillator pad to be placed, okay, for the cardioversion. And this is used in case of atrial tachydysarrhythmias, mainly for AF, atrial fibrillation, and the pad in the anterior posterior pad position is the preferred one. Okay, then the anterior lateral placement, and defibrillator biphasic. Okay, monophasic is also available, but if biphasic is having more advantage, and it is easy also, and helps in terminating the dysarrhythmias and helping or converting to the normal rhythm. So especially when we use this for the atrial fibrillation, the joules to be used is 120 to 200 joules. For flutter, we can go for the lower joules, okay, 50 to 100 joules. And for VT, okay, we can select the 100 joules. So it depends on the dysarrhythmia. VF again we can start with the 200 and it can go up to the 360. So depends on the dysarrhythmia. Again, the energy requirement is also differs. Okay, but important side effect or the common complication due to cardioversion is the thromboembolism. Okay, the patient can go for the thromboembolism. So important nurse's responsibility is to reduce the risk or the complication of the thromboembolism following the cardioversion. So how we can prevent or reduce this is by administering the anticoagulation therapy. Even before the cardioversion itself, we can give this anticoagulation. It is recommended so that we can prevent the complication of the thromboembolism. Okay, for atrial flutter, electrical cardioversion is mostly used because it is very successful, mainly in case of atrial flutter. Okay, atrial flutter itself, different types. So this electrical cardioversion is mostly useful, and type 1 atrial flutter can be cardioverted with lower joules, that is 50 to 100 joules or even lesser than that also. Okay, for supraventricular tachycardia, okay, cardioversion is beneficial one. So here this helps in terminating by the vagal maneuvers and with other antidysarrhythmic medication, especially adenosine or verapamil. Already we have seen different the classification of the antidysarrhythmic drugs. Okay, still the arrhythmia persists, then we can go for the electrical cardioversion in case of patients with supraventricular tachycardia. And ventricular tachycardia also, still patient is having distinct QRS or T wave. If it is identified, then we can go for the synchronized with the Qrs complex. And monomorphic ventricular tachycardia also can be used this to terminate the dysarrhythmias. And non-synchronized defibrillation, it should be used with the 200 joules. Okay, especially using biphasic defibrillator. And for VF, ventricular fibrillation, the CPR. Okay, CPR is one of the important the emergency procedure. So resuscitation, if it is performed prior to the defibrillation, then prognosis seems to be better. So CPR, then defibrillation. Okay, so that sequence helps in the more prognosis. And the complications of this procedure, again, due to cardioversion. Cardioversion is mainly used to revert to the normal rhythm. But sometimes due to cardioversion, patient can go for the dysarrhythmias also. So we have to continuously monitor the ECG and hypotension, check for the hypotension and any other due to pad placement, skin irritation. And sometimes patient can go into life-threatening complication also after the cardioversion arrhythmias. Okay, due to the thromboembolism. So we should prevent and take care of the complication of the thromboembolism. So that is about the external. Instead of external, we can go for the internal also. Okay, that is intracardiac cardioversion. Okay, so here intracardiac, instead of keeping that the placement externally, it can be kept okay in the internal cardioversion. Okay, and that helps in delivering the energy. Okay, so the wire will be placed in the epicardium. Okay, after surgery or during surgery, it can be placed in the epicardium, and the paddles also will be placed inside. Okay, and the other procedure is the same. Okay, so that is about the internal cardioversion. So external cardioversion is done manually, internal cardioversion. So according to the type of dysarrhythmias and availability of the facility, we have to select whether we want to go for the external or the internal. But internal also, it has again has its own complication like decreased cardiac output, okay, and pericardial effusion. Okay, these are all the important emergency complication. And other than this, bradycardia. Okay, so sometimes it may require the temporary pacemaker also to manage this complication. Okay, so implantable, other than the internal cardio version, implantable cardioverter defibrillator is also available, ICD. Okay, so ICD, again, if a patient sustained this VT for a longer duration, then this ICD can be used. Advantage of using this ICD, okay, we can prevent the whatever the side effect we have seen due to the external shock can be prevented using this implantable cardioverter defibrillator. That is the advantage. Okay, so defibrillation already we have seen which are all the condition needs defibrillation, ventricular fibrillation, and pulseless ventricular tachycardia. These are all the two important condition need of defibrillation. Some of these steps you must remember. Okay, CPR should be in progress. Okay, good. The quality CPR should be in progress. Okay, till you get the defibrillator. And once you get the defibrillator, turn the defibrillator, select the required amount of the energy, and check the synchronizers, the switch to be off while giving the defibrillator. Only during the cardioversion, it has to be synchronized. Then apply the pad, okay, in the right side of the sternum, just below the clavicle, and the left side of the apex, and then deliver the joule. Okay, so again, if biphasic, if we take lower joule and with the less, no need to repeat again the joules. If we use monophasic, then it requires a more number of the energy or the joules. So these are all some of the points you must remember. Other than this defibrillator, catheter ablation, that is also one of the important management for dysarrhythmias. Okay, mainly this is used for the atrial fibrillation. Okay, so atrial fibrillation here, high frequency, low energy sound waves, okay, are passed through the catheter. Okay, it is similar like the cardiac catheterization procedure. Either we can use the ice or we can use the thermal, so that it go and injure the particular tissue where which stimulates the abnormal rhythm. Once that particular tissue is destroyed, then it will revert back to the normal rhythm. But it requires the sedation in the theater and IV heparin, and again continuous monitor and resuscitative equipment all should be there. Still, if it is persistent and symptomatic, okay, then this catheter ablation will be more useful along with the antidysarrhythmic medication. The goal is to modify the sinus node without ablating it completely. Okay, that is a main aim and need for the permanent pacemaker. So, without going for the permanent pacemaker, we can manage the patient with the catheter ablation. But catheter ablation also has its own risk or the complication. Important complications are AV block, pericardial tamponade, and phrenic nerve injury, stroke, hematoma, retroperitoneal bleeding, pulmonary vein stenosis, and atrial esophageal fistula. These are all the important complications due to catheter ablation. If you see the nursing care, it is similar like a cardiac catheterization procedure. Before, during, and after the procedure, nurse's responsibility is very important. And other than this cardiac ablation, pacemaker. So pacemaker, already all of you must be familiar about the pacemaker, temporary kind of pacemaker or the permanent kind of the pacemaker. So it is the artificial cardiac pacemaker. It is one of the important device used to pace the heart. Okay, to have the normal conduction pathway. Once that conduction is disturbances, then we can using this pacing wire, we can regularize the normal sinus rhythm. So pacing the atrium or both, ventricle also, depends on the type of the dysarrhythmias. We can select the mode also, whether we want to pace only the atrium or ventricle or both atrium and the ventricle. And anti-tachycardia pacing or anti-bradycardia depends on the dysarrhythmia. All this can be selected. And permanent pacemaker, some the patients with the dysarrhythmia are in need of the permanent pacemaker. So which are all the patients require permanent pacemaker, like AV block and AV block, especially second and third degree AV block, or AF, atrial fibrillation, bundle branch block, cardiomyopathy, heart failure, SA node dysfunction, and ventricular tachycardia. Okay, so this permanent pacemaker will be implanted within the body, and again that power source also will be placed subcutaneously. Okay, so over the pectoral muscle, and it will regularize the normal rhythm of the patient. And temporary pacemaker, sometimes all the patient will not require the permanent pacemaker. Temporary pacemaker, similar kind, but that pacing wire will be outside. Even it can be done in the ear. So power source will be outside the body. In this, three types are there: transvenous, epicardial, and transcutaneous. Okay, so transvenous is that pacing is placed in the right atrium and right ventricle. Epicardial is only used in the surgery, mainly cardiac surgery, and the transcutaneous again placing the pad. Okay, so pad and on the anterior chest, okay, and one at the back between the scapula or the spine and the left side. It can be placed and pacing can be done temporarily. Only preparation of the patient is important. And indication for this temporary is prophylaxis, especially after CBG surgery or MI, inferior type of MI or AV block. All this patient requires temporary pacemaker. Okay. So I think the overall management I have discussed is starting from the ER. When we receive the patient in ER, what are all the initial assessment to be done and emergency management? Once patient is stable, what are all the other management starting from vagal maneuver, carotid sinus massage, and other maneuver and drugs we have discussed in detail, different classification, nurse's responsibility, and we have seen the other management like cardioversion, different methods, and we have seen defibrillation, and even we have seen the external defibrillator devices and cardiac ablation, pacemaker, temporary and permanent. So this is the overall management of the patient with the dysarrhythmias. And if we see according to the dysarrhythmias, then it goes in detail. Because I have prepared that, but I have attended the previous session. So I think time is also getting, so I will just skip this. Only I will tell sinus, the bradycardia, sinus bradycardia, only oxygen and the drugs. Okay, so important drug is the atropine sulfate. Okay, the atropine sulfate is very important drug. And the sinus tachycardia, you can see the ECG already it was discussed, and you can remember the etiology and the treatment. Very important treatment is the calcium channel blocker. Okay, for this sinus tachycardia. Still hemodynamically unstable, then we can go for the cardioversion. Okay, and adenosine drug is very important. And other than that, cardiac ablation. Okay, so this is like a flow chart kind. Depends on the stable and unstable, we can select the treatment modality. And the atrial flutter, already in the previous session it was discussed. In the atrial flutter, the important the antidysarrhythmic drugs. Okay, these are all the different group of drugs. Other than that, cardioversion, vagal maneuver, and anti-thrombotic therapy and the catheter ablation. So these are all the important treatment for the atrial flutter. And atrial fibrillation, again oxygen administration, anti-thrombotic drug, and dysarrhythmic medication. Okay, and cardioversion. These are all the important management. Anticoagulation therapy is very important to prevent the complication. Okay, if depends on the criteria, either aspirin or the warfarin can be selected. Okay, as an option under anticoagulation therapy. And other than this, some of the very rare procedure called maze and mini. This is also one of the procedure. Okay, especially used for the AF that helps in interrupting the ectopic electrical signal. Okay, so that helps in converting from the AF to the normal. Okay, that is called the maze and the mini maze procedure. And this is a scoring system to be used before selecting the thrombolytic agent. And paroxysmal supraventricular tachycardia. Okay, the treatment is vagal maneuver. Already we have discussed how to do. And adenosine is the drug of choice. Okay, and the paroxysmal supraventricular tachycardia, again adenosine. Some of the points we should remember when we administer the adenosine. We have to monitor the ECG continuously, and some period of asystole may be common when we administer the adenosine. Okay, and we have to observe the patient for flushing, dizziness, chest pain, palpitation. All that is very important. And for premature ventricular contraction, same may identify the cause and treat the cause. Especially electrolyte imbalance to be corrected, oxygen, and then antidysarrhythmic medication. Amiodarone is the treatment of choice. Heart block, again, type of the heart block, the ECG, it was discussed in the previous session. No treatment required. Okay, for the first degree heart block. And again, second degree heart block, pacing. Okay, temporary pacing. And third degree, again, we have to monitor the continuous ECG and treat the condition. Symptomatic, if patient is having dyspnea, then treat the cause. Okay, then BT, previous speaker have taken both the ECG changes along with the management also. She has taken very in detail beautifully. So I will skip for this also. The management for the ventricular tachycardia. So only if the pulseless type of the ventricular tachycardia, defibrillation is needed. For monophasic ventricular tachycardia, cardioversion. Okay, so depends on the types, we have to select the treatment. And ventricular fibrillation, again, it is the one of the important emergency and shockable rhythm. We have to follow the ACLS protocol also. This is about the ACLS protocol for ventricular fibrillation. And the same protocol was discussed in the previous session. So I'm skipping this. And asystole is also one of the important dysarrhythmia. So CPR and ACLS protocol, epinephrine, vasopressin, and if needed, intubation. And PEA, again, the important cause is hypovolemia or some of the metabolic acidosis. Treatment includes CPR, epinephrine, and if needed, intubation. Okay. So in detail, we have seen the dysarrhythmias and its management, and we have even seen according to each dysarrhythmia what is the treatment choice. So to conclude the session, the nurse's important responsibility, they should have skill or ability to recognize the ECG rhythm, whether it is the normal or abnormal, because we are the one with the patient either in the ER or in ward. So we have to identify, we should be able to recognize and we should be able to report to the physician and we should be able to initiate the treatment. So assessment is very important and the important responsibility while administering medication also we have discussed. So thank you so much for the given opportunity. Thank you.
Thank you, ma'am, for sharing your valuable knowledge with us.
I think I have completed on time.
Yes, ma'am. Thank you very much. It was very helpful for the students to learn
You
how
can
to
share
manage.
this PPT also for the students because in between for time I have rushed. So maybe you can share the PPT if they appear.
Okay, ma'am. If anyone have any queries, they can put questions in the chat box below. Yes, the PPT will be shared. I guess, ma'am, there are no doubts. So thank you very much, ma'am, for being there with us.
Thank you. Thank you so much again, once again, for the opportunity given for me to be a resource person in this national webinar. Okay, so thank you so much.
Thank you, ma'am. Now I would like to request Ms. Aarti to give vote of thanks. Aarti, over to you.
Good afternoon to all. I'm privileged to
Good afternoon to all. I am privileged to propose the vote of thanks on behalf of the Medical Surgical Nursing Department of MGM Bombay College of Nursing, Navi Mumbai. I would like to thank all the honorable resource persons, Mrs. Sri Devi, Dr. Shilpa Kadam, and Dr. Parkodi Arjuna, who bless us with their and presence and share their valuable insight. On the behalf of the organizing committee, I convey deep regards and heartily thanks to our organizing chairperson, Dr. Prabhake Dasila, Professor and Director of MGM Bombay College of Nursing, Navi Mumbai, Organizing Secretary, Dr. Ponchitra, Professor and Vice Principal of MGM Bombay College of Nursing, Navi Mumbai, and Organizing Co-Secretary, Mrs. Sujan Jacob, Professor and IQSC Coordinator, HOD of Medical Surgical Nursing in MGM Bombay College of Nursing, and Organizing Convener, Mrs. Farganzia Jubilsan, and Assistant Professor of MGM Bombay College of they help us in obtaining the necessary administrative approval for organizing the event, and also the supported in all possible manner to organizing the national webinar. And I would like to thank also the meeting sir for helping in the IT support, and also Mrs. Sarika Lokhandanam for help us in the registration process. At the end, I would like to thank all the committee members for this guidance and the support. Thank you so much.
Thank you, ma'am, Dr. Potpudi Arjunan. Thank you so much for accepting our invitation in a very short notice and sharing your valuable insights with us, ma'am. Thank you so much, ma'am.
Thank you. Thank you for the opportunity.
Thank you. Thank you, dear participants. Thank you.
Post-test link is been put up in the chat box. You can fill the post-test as well as the
Feedback forms. Thank you for being there with us. Kindly fill the post-test and feedback forms. You will receive your e-certificates within 1 week.